Hi and good morning to everyone. I welcome you all for the HTIC Healthcare Conclave. The HTIC Healthcare Conclave will be conducted once in every quarter, and this is the sixth conclave which we are conducting in collaboration with iConnect. iConnect is a 75 industry connect events to showcase the achievements in various science and technology areas. IITM HTIC Healthcare Conclave has been selected as one of the 75 iconic events, and we are so excited and happy to host this conclave on the topic of rural technology. The aim of this series is to bring successful entrepreneurs, technical and business experts from the different domains under healthcare to share insights and to discuss the upcoming trends, innovations, technologies and bottlenecks. This is the conclave comprises of two panel discussions, expert sessions and startup demos. Now I would like to welcome Mr. Muthusingaram sir, who is the CEO of IITM HTIC Medtech Incubator, and Dr. Mohan Shankar Sivaprakasam sir, who is the faculty in charge of IIT Madras HTIC. I would also like to welcome Dr. Alka Sharma, who is the DPT Senior Advisor H Medical Biotechnology Division, Director at Government of India. We are delighted to have you, ma'am, in our conclave. Today we are going to see about innovations and technologies which are used and deployed in rural areas. I hope the participants will gain the knowledge and benefited through this session. Now I would like to hand over the forum back to Harshini. Over to Harshini. Thank you.
Thank you so much. I would like over to you, sir.
Ashni, I couldn't hear you. Have you handed over to me?
Yes.
Yeah, thank you. Thank you very much, Dr. Alka. It's absolute pleasure. I sometimes things happen in a certain way which would not summarize it better if I had said it. So the whole HTIC started with Dr. Alka Sharma way back in 2009. So it's a very interesting journey. If you look at it, in one way, it reflects the government's role in shaping up medtech innovation in India. So about 12, 13 years ago, I would say, is when the seeds of bringing together industry, academia, entrepreneurship, all of it started. And BIRAC actually started around the same time as HTIC. So in fact, every time I hear a BIRAC's annual thing, I know that HTIC has also become 1 year older. So it's an absolute pleasure. I just want to make a couple of points specific to where medtech and rural is going. So if you had asked me about 5 to 7 years ago, is there a role for medtech in rural? I would say yes, but um, in a more not-for-profit manner. That would be my answer about 5 to 7 years ago, maybe even 7 to 8 years ago. But now things have changed. If you watch the allocation of healthcare budget, both from the state and from the center to the rural areas, directly focused on technology-enabled healthcare, they're significant. Many of the state budgets, particularly, see, we focus on the center budget. We have not realized that state budgets are now upward of 5 to 6% of the state budget that's directed towards healthcare. Right? And most of it specifically is focused on public healthcare and rural health. So, as an entrepreneur, your market is not just limited to tier 1 cities anymore. And this is very important. And we have seen this evolution in HTIZ and specifically the Medtech Incubator, where we have over 45 startup companies. In fact, a couple of our startup companies have actually had larger success in rural areas and larger public healthcare. So this is very important. There is a fundamental shift that's happening. You will realize that both from the digital aspect of putting all the healthcare aspects together through the ABDM type of programs, and from the state in connecting rural areas to the larger healthcare ecosystem. So fundamentally, you are seeing a larger business opportunity. Let me use that word specifically. Now, there is a challenge also, which is your normal way of price points and service contracts directly do not work in rural settings because they're fundamentally distributed, fragmented, and smaller price points. But of course, they have a larger volume if you do it together. So you have to very smartly maneuver this in a way that you still have a successful business while you're serving this. So we have had a lot of experience, as you know, I mean, thanks to people like Dr. Alka Sharma. HTIC has become so successful that we are very proud and sort of delighted to serve the community in any way possible. We are doing that. And whatever help you need, both technically, business wise, we almost have an answer, or we will find a person who has an answer. We have rarely said no to anybody who has sought after help from us. So, and you're in able hands with somebody like Muthu, who has had experience in 3 different continents, also has a global picture of in terms of capital, fundraising, business, how to scale it, sometimes how to even shut it down when it's not working. So you cannot find a better person. So I'm just here, absolutely happy. Whatever you need, we are here to help you. Thank you very much.
Now I would like to
Can't hear you, Harshini.
can you hear me? Yeah. Dr. Hardeep?
Yes, Harshini, thank you. So, good morning, everyone. Welcome to this quarterly session of the cluster, the Healthcare Conclave, organized by HTIC. Special welcome to Dr. Alka Sharma once again to this Healthcare Conclave. So, I would just like to give a brief introduction and update about the cluster itself. So, the Tamil Nadu Bioness cluster is one of the clusters under the umbrella of the Bioness scheme run by BIRAC, and it consists of members from across Tamil Nadu and Tirupati, including 10 members: HTIC, IIT Madras Bio-Incubator, Sastra University's Crescent Innovation Center, PSG STEP, SPMVV Tirupati, my own institute, Sri Ramchandra Innovation Incubation Center, VIF Tanuvas, VIT Technology Business Incubator, as well as finally the Golden Jubilee Women's Biotech Park in Chennai. So all of these incubators are running quite well since a few years under the Bioness scheme of BIRAC. And cumulatively, we have around over just around 200 or more incubatees or startups who are working with us at these incubators. And all these incubators are running different schemes for the benefit of entrepreneurs, startups, and even students and faculty members to get into the entrepreneurship pipeline. Like HTIC is organizing various sessions such as Ask Me Anything or Knowledge Tuesdays and Founders Tuesdays in collaboration with the cluster members. And all these information sessions or learning sessions are open to all the people across the country and even outside. It's not restricted to the members of the cluster. There are also other programs which are run by other incubators for knowledge sharing, like Sri Ramchandra Innovation Incubation Center runs programs for faculty and students every fortnight, while Sastra University, Crescent Innovation Center, Tirupati University, all of these run a lot of educational programs and learning programs for startups. Also, many schemes are being run by different incubators like VIT, such as VIT for under Nidhi Prayas along with HTIC, Nidhi Prayas, Nidhi EIR schemes or funding schemes for startups and innovators to help kickstart their projects. So the entire cluster is doing a lot of work in at various levels to promote entrepreneurship within the community and within the local community, as well as leveraging this experience to push at the national levels. Along with this, HTIC is actually taking a very good lead in this cluster because they are also helping other incubators, other more nascent incubators to help with co-incubation with startups. So this also allows the other incubators to flourish along with HTIC and the other established members. So a lot of activities, collaboration and cooperation is something that runs through all the members of the club of the Tamil Nadu cluster. And I am very happy that I am actually part of this cluster. and have received very good help from all members across the board, whether it be in terms of schemes or SOPs or processes that need to be incorporated or some events that need to be organized. So it has been a very good experience for me at a personal level. And just as one of the events that are upcoming, we had planned a startup Tamil Nadu cluster startup conference come showcase. It was actually tentatively planned last week to coincide with the BioRack Foundation Day event or biotech startup event at New Delhi, but had to be postponed on account of that event. So now it is tentatively planned on 20th of July, where two startups from each incubator will showcase their products in front of investors for for an opportunity at investment from ventures, and also there will be sessions on digital healthcare and other startup progresses that most of these companies will benefit from. So we are looking forward to more such events and more collaborations with BioRack amongst each other and other members of the Bioness community across the country for a flourishing entrepreneurship ecosystem within the region. That's all from my side. Thank you very much.
Thank you, Dr. Hardeep. Now I would like to welcome Dr. Alka Sharma, DBT Senior Advisor Scientist H Medical Biotechnology Division Director at Government of India. So Dr. Alka Sharma is dealing with research and policy issue in emerging areas of biotechnology. She has made significant contributions in medtech innovation with national and international partnerships, early and late translational research on various domain-specific areas of biotechnology, such as vaccine research and development, diagnostic stem cells, and regenerative medicine, biomedical engineering, biodesign setting up bioclusters across the country for innovation-driven research, technology, and product development. She has been instrumental in promoting and supporting public-private partnerships across the country and also for commercialization of indigenous and affordable technologies for a large number of patients in urban and rural settings. Her efforts have resulted in creation of several startup development of functional biomedical device prototypes, transfer of technologies, creation of a pool of medtech innovators in the country. She is actively involved in formulating various legislations in biotech sector and heading the biosafety regulation division including RCGM in DBT. She is the coordinator of management of COVID-19 related activities in DBT BIRAC and also contributing towards Atmanirbhar Bharat through National Biotech Research Indigenation Consortium NBRAC. She is the scientific coordinator of 4 autonomous institutions of DBT and also coordinating scientific activities of ICGEB. She is proactively promoting and supporting bilateral partnerships with various countries such as USA, Sweden, Finland, France, and Australia. She has received training at the Department of Microbiology and Infectious Diseases, NIH USA, for the management of extramural programs. She has also received CSIR Technology Award for Innovation for her translational work. Happy to have you with us today, ma'am.
Thanks, Ashini, for a long introduction, but thank you so much. So, first of all, a very good morning and namaskar to all of you. I'm so happy. It's my pleasure to be a part of today's event. As all of you know, that 75th Azadi Ka Amrit Mahotsav is being celebrated across the country to mark our 75th years of independence. Under this umbrella, the Ministry of Science and Technology has taken an initiative collectively with its all departments and such as DBT, DST, CSAR, and also Ministry of Earth Sciences to organize iConnect event, that is Industry Connect. Under this initiative, a total 75 events now being organized by all the departments of science and technology and also from Ministry of Earth Sciences, along with participation of 75 industries. And all these 75 industries will be connected during the entire iConnect events. And I would like to inform you that Department of Biotechnology alone is organizing 18 events with all its autonomous institution and with its PSU BIREC. Being the MD of BIREC, this is my responsibility just to see that all industries are connected during iConnect. And I think the HTIC is the best place actually for this kind of event. And today I'm a part of this event and I can see the list of participants who all are participating in this event. So today's event is one of them in the iConnect event, and As Dr. Mohan said, actually, the STIC is not new for me. And if you really see that the way STIC was established earlier, when Dr. Bhan is the vision of Dr. M.K. Bhan, and under the leadership of Dr. Ashok Jhunjhunwala, Dr. Mohan and his team, and we collectively as a team, we worked really very hard to put everything in place when STIC was in the process of establishment. And when you do something like HTIC, it's not in a routine manner. Actually, you can do. There a lot of efforts are required, and I'm happy that the team which was working at that time was a very competent team and enthusiastic team under the leadership and guidance of Dr. Bhan. We will be able to do that, and now I am seeing HTIC growing in this manner. I'm really very. I have no words to say, but we're so happy to see that the connectivity, networking of HTIC, which has with other stakeholders and partners. So now, actually, now I'm from speaking from. So my responsibility is now much more than I was in only in DBT. So I'm holding additional charge of MD Bayrek also, in addition to senior advisor at Department of Biotechnology. So now HTIC, I'm seeing that this is also one of the 64 bio-incubation centers supported by BIREC, and efforts of Government of India and BIREC for various government schemes and opportunities to support and nurture the healthcare domain. It is already where that this network is now growing, and more than 60% of BIREC supported goes into the healthcare sector. So it's that's why I'm saying the STIC one of them, and it's really connected very well with all industries and all other stakeholders. So this is focused on medtech domain, and it brings together startups, entrepreneurs, technologists, engineers, doctors, and healthcare professionals, industry and government to develop healthcare technologies for the country. The STIC healthcare now is what is being organized. The aim is to bring successful entrepreneurs, technical and business experts from different domains under healthcare to share insight and to discuss the upcoming trends, innovation, technologies, and bottlenecks. So it brings the best of minds in the medical and healthcare industry to share the progress and the challenges in different sectors. And as the theme suggests, this conclave, what we all are organizing here, the focuses on rural technology in particular, to use technology interventions to improve healthcare in low setting. So today it can be seen that technology has made many aspects of life easier for people living in rural and remote areas. However, lot is still to be done. Our startup should come forward and provide solutions that support instant communication and connection along with devices and machines that reduce the reliance on city or urban based facilities to improve daily livings. So the government push to promote technology deployment, telemedicine and telehealth along with Make in India campaign is driving the growth of the sector and is ensuring that rural areas have access to high-end healthcare services. Schemes such as Ayushman Bharat Health Infrastructure Mission and Jan Arogya Yojana focused on providing state-of-the-art healthcare facilities. In addition, the numerous health projects such as National Digital Health Management, Ayushman Bharat, telemedicine services, e-Sanjeevani, National Rural Health Mission that are very relevant to the rural community and that have already been initiated. So as per the Invest India study, 100% FDI has been allowed by the government under the automatic route to invest in developing hospitals, and adding to it 100% FDI is also permissible under automatic route in medical device manufacturing, and doctors are being trained, MBBS and as well as postgraduate seats are being doubled, and investment in hospitals are witnessing a surge to meet the increasing demand of healthcare workers in the country. So the healthcare sector is one of the major and strongest pillar of our country, and BIDEC, as you all know, is an interface agency and strives towards strengthening and empowering the biotech enterprises to undertake strategic research and innovation, addressing nationally relevant product development needs. So since its inception in 2012, when BIDEC was established in March 2012, and also Dr. Mohan mentioned in his remarks, so close actually it's very close, but later than STIC. So that BIOTech has acted as a development agency to lay the foundation of a biotech ecosystem in the country. The vision of the organization clearly defines its core philosophy to create societal impact through cutting edge products and that are affordable and address the needs of the largest section of the society. So, over the last 10 years, now very recently, we concluded Biotech Startup Expo at Pragati Maidan, and many of you were the part of that expo, and then that was celebrated in, after completing 10 years of Biotech, and that has been instrumental in building and expanding the biotech startup ecosystem in the country. The speaker, I have seen the panel discussion in speaker session, practicing the area of rural technology, in particularly to use technology intervention to improve health care. And hope deliberations during the session today would be very, very useful in bringing out the key issues in the sector. Looking forward to having a fruitful discussion. Wishing you all the very best for the event to be a grand success. Thank you.
Thank you, ma'am. Thank you for your time. Thank you for joining us today. Requesting all to kindly go on camera for us to get a picture. Thank you, ma'am. Thank you so much. Thank you for your time for joining us today.
Thank you. Thank you very much.
Yes, ma'am. So moving on to the next part of the session, today we have with us the first panel discussion on future of rural regions grasping technological change, usage of technology in rural development. To moderate the session, we have with us Dr. Deepa, Associate Consultant, Department of Minimal Access Surgery, Bariatric and Gastrointestinal Surgery, Manipal Hospital. She also has her expertise in trauma surgery, pain management, and critical medicine. And in the panel, we have with us Dr. Nandakumar, co-founder of Ashwini and former director of Ashwini Gudalur Adivasi Hospital, Gudalur. We have with us Dr. Lavnish Bain, associate professor, Department of Surgery, Maulana Azad Medical College and Lok Nayak Hospital. We also have with us Dr. Sheila John, head of teleophthalmology and e-learning department, Shankar Netralaya. We also have with us Dr. KC Sharma, chief consultant surgeon, Udhampur. Over to Dr. Deepa to set the pace for the session. Over to you, ma'am.
Thanks, Ashwin. I'm not able to see Dr. KC Sharma and Dr. Lavnish Benz. Have they joined?
Dr. Lavnish will be joining in another couple of minutes, ma'am. Dr. Sharma will also be joining.
Sure, sure. So shall we start or should we wait?
Yes, ma'am. Just get started. I'll get them on.
Yeah, sure. Thank you. So good morning, everyone. As Harshini has already told, my name is Dr. Deepa. I'm an associate consultant with Manipal Hospitals. The reason why I'm here with this forum is because I'm really interested in rural surgery, and I realize that there's lots to be done there. The way I was introduced to this team of HTIC and Dr. Singaram was we had actually conducted a conference in Delhi looking at the innovations in global surgery. And I would say organizing that was a real learning for me because that is when I realized we were a group of clinicians who were trying to organize it. And we realized that we are not aware about what is actually happening. There's lots happening, a lot of government-private collaborations which are happening, a lot of schemes that the DBT, DST have started, but the students, medical students, clinicians have to take the initiative to understand what's happening and to get actively involved in it. Because two main points where we come in this innovation journey is to identify the need, because we work directly with the patients. We are the best people to actually identify the need which is required and then collaborate with the startups, the incubators to develop the prototype and take it forward. And also once a product is developed, to again test it back, to have the clinical trials. That is another place where our role comes in, because only when we have confidence in what has been worked on, only then we'll be willing to actually test it on our patients. So those two important areas we identified were actually gaps which were existing. And there is a need to collaborate and work together to close those gaps. So so we are going to be the connecting link to get technology to the rural areas. How can we do this better? So the reason for this panel discussion was mainly to address that. So the panelists for our discussion today, can we go to the next slide, please? They're all change makers in their own way, I would say. Dr. Sheila John, the head of Department of Teleophthalmology and E-Learning, and a member of Indian and American Telemedicine Associations, has worked extensively in the community of ophthalmological services. And she has been instrumental in setting up teleophthalmology mobile vans, which is actually helping in taking the medical services to the doorsteps of the underprivileged in rural India. Dr. Nandkumar Menon, who is a recipient of Surgical Humanitarian Award in 2018 for the decades that he has actually dedicated and continues to dedicate to provide sustainable, equitable medical services and training to the indigenous Adivasi people of southern India in Gudallur, Nilgiris. Welcome, Dr. Sheila, Dr. Nandkumar. Dr. KC Sharma, who is yet to join, I guess. Yeah, he's a surgeon and innovator, and he's also a recipient of the ASI Social Services Award for his services in the remotest rural areas of Jammu Kashmir. So we have the south and the north covered here. And Dr. Lavnish Bains, who's an associate professor surgery at Maulana Azad Medical College. He's been instrumental in actually working with the University of Leeds, coming up with a prototype and actually utilizing it in applying it in the rural areas, running it through clinical trials. And he's actually taken it through the entire journey and shown how it can benefit the rural surgeons. So welcome all of our esteemed panelists to this discussion. Next slide. So the first question which came to my mind when I heard this is technology really penetrating into our rural India, or is it just confined to cities? And I was actually pleasantly surprised that the COVID pandemic has proven to be a boon in this way, I would say, because of the COVID pandemic, most of us went online. And even in the rural India, it was seen that nearly 27.9% of the households had brought in a new smartphone because they had to do that for their children's education. So this was a jump from 9.1% to 27.9%, which I would say is a definite improvement. And the availability of smartphones in rural India is actually doubled from 2018 to 2021. So there is even a 45% growth in active internet users in rural India. So smartphones, all of us know, is something which is penetrated in each and every one of our lives. But how far has technology penetrated for rural healthcare? Next slide. So actually, there are a lot of technological advances being made and which have shown to be improving rural healthcare. So this is rural. Usually when I think of rural, I think of rural India, but rural can be there all across the world. And it has benefited rural healthcare across the world in these areas of telehealth and virtual healthcare. Electronic medical patient records maintenance is a technology which has improved healthcare, because by that, how often to follow up the patients, how better to administer care for them, that can be easily done. Having mobile health units, virtual reality in medicine training module. So this is something which is coming up in a big way now. And this is something which our rural surgeons can really benefit with, sitting in their own confines of the remote areas. They can get access to high quality education and training through these modules. Next slide, please. So as clinicians, we're always told this statement that the eyes don't see what the mind doesn't know. So we have come to a point where we know that technology has become a part of our lives, and it is imperative to learn to use them efficiently. So the onus is on us clinicians to learn and adapt. So irrespective of the geographical or socioeconomical area of our work, technology is here to stay. So I would say it's time to open our eyes and minds to it. Next slide. So I would like to have this session as a few questions, which I would like to have our panelists think through and discuss. So first, is there a perceived need to implement technology in rural healthcare? So I'm sure Dr. Nandkumar, maybe we can start with you. With your experience in rural healthcare, do you really think there is a need to implement technology?
Yes, definitely. As you said, technology is now universal, and the advances that are taking place can definitely, and not just definitely, we have to use it in rural areas, because remember, rural areas have far fewer health professionals working. Therefore, for us to connect with what is happening and to get advice from consultants in cities, there's no better way than using technology. So I think it's of paramount importance that technology penetrates into the rural areas so that the advances that are taking place can be shared with the rural people.
So as Dr. Nandakumar mentioned regarding telehealth, I guess the best person to explain about telehealth to us will be Dr. Sheila. Dr. Sheila, can you please let us know how telehealth is helping and how has it helped address this need?
Taking specialist care to the rural villages, especially eye examination, comprehensive eye examination to be done at their doorsteps. We started mobile units in 2003, but at that time, internet connectivity was very poor. So we started with Indian Space Organization giving us satellite dishes, which can be mounted on top of the bus. So you go in the rural villages, and with help of GPRS, we connect to the satellite on top of Bangalore. And we used to do teleconsultation. Even in the remote regions, it used to work well. We used to do comprehensive eye examination. At that point, we did not have an EMR. By 2010-11, we developed electronic medical records because we had to carry paper from place to place. And the patient's records, unless we locate to attach again to the problem. So we shifted into electronic medical records. And then imaging also became feasible at that time, where we could take the images and then connect to the EMR and share it with the consultant. And it goes into storage also. So if a person of diabetic retinopathy comes, he doesn't have any changes. 2 years later, he comes, he has changes. Then treatment is done. Everything gets followed in the EMR. And second, we could shift this EMR into the base hospital EMR. So that was very, but we did not have an online EMR which connected to the hospital. We developed an offline EMR where we used the hotspot there, connected 5 computers together, and we could do the demographic details and all examinations at various points. This EMR, we used to come to the base hospital and upload it. And in the EMR, the fundus images, anterior segment images used to be uploaded. By 2011-12, we shifted to internet connectivity. But even then, the connectivity was poor. By 15-16, vastly improved. And now by 2020, it's really improving. It is only the very remote areas where the population is very less, the cell phone towers are not built into it. No matter who the provider is, when the population, rural population is very less, they do not have towers. But most of the areas, internet connectivity is feasible, and we are able to do teleconsultations. Patient also be in the laptop with a speaker on. Patient is able to interact with us. The patient's attender also interacts. So we have about 20 patients who undergo teleconsultation. We decide who are the patients who have to come to the hospital and for what duration. Do they need a medical treatment, surgical treatment? Everything is discussed with the patient and they're brought over. Of course, other than the basic examination which is done, investigations are available only in the hospital. Even now, we have only an offline EMR using a hotspot. We do everything, bring here. Now we have video conferencing softwares where earlier what we used to do is convert the EMR to a PDF, put images, and use Google Drive and do it. But now there are softwares, video conferencing softwares where you can go to the computer, do the share option, and view everything there itself. All that is feasible now. It's much easier, but the main problem now is the electricity. In rural villages, electricity is much less. So we have to have a generator. We were trying for solar panels, but again, to carry them in the bus and everything, we had difficulties. Second thing, this internet connectivity in very remote areas, we still have problems. We are not able to manage. Because video conferencing needs 512 kbps. It's not below that you can do. So we used to share by email or over phone and bring those patients to the base hospital and have it done in areas where we cannot connect. So right now, that is what we are following. Comprehensive eye care is given to everyone, so that the basic screening, whether they're normal patients or they have a disease, is determined there. And by teleconsultation, we consult the patients and tell them exactly what to expect in the base hospital. And free treatment is provided for these people at the base hospital. And as we go from place to place, we have their records also saved in our EMR.
Wonderful work, Dr. Sheila. Yeah, so I mean, I guess what I got a gist from it is even if there are lots of adversities, when we try to look for solutions, we do find them. Because you had so many problems coming up, but then you always found some solution to it. So in the South, I guess usually it's said to be slightly better. I don't know what's the situation in the North. Is Dr. K.C. Sharma here? Maybe he can highlight what are the needs that he felt in his area of work in the North. Harshini, is Dr. Sharma here?
Ma'am, can you hear me?
Yes.
Yeah, Dr. K.C. Sharma has got some issue in his laptop. He's trying to fix it. So he'll be
Sure.
joining another 5
No
minutes.
issues, no issues. And Dr. Lavnish?
To join. Can you hear me, ma'am? Yeah, Dr. Lavnish also is trying to join. He's in surgery, so
Okay.
he's some last minute medical emergency in his hospital.
Sure. So just let us know when they join because I'm not
Sure.
able to see the entire panelist
I'll do it.
view of it.
I'll do
Yeah.
it.
So I guess we continue with our discussions then. So Dr. Nandakumar, I would like to ask you the next question. Okay, we do identify that there is a need, but what are the challenges or the barriers that we face when we try to incorporate technology into these areas of need?
As was mentioned, internet connection is probably the most important. Once one has internet connection, there's a whole lot of things that we can do. So in our hospital, for example, we've been using WhatsApp very effectively, and we have various WhatsApp groups. For example, orthopedics, neurology, and so on. So, for example, in orthopedics, when we have a patient who has a possible fracture or a fracture has been reduced, we send the pictures over to our consultant orthopedic surgeons who are our friends and who then give us a result usually within a half an hour. So this is a fantastic improvement in our care because uh, previously when we reduced fractures, we did not get that extra help and reassurance that we are doing the right thing. So it's been a tremendous help to have the consultant send us a report. The same with radiology. We've been sending our CT scans to be read, and usually overnight we get the reports. So if it's urgent, we can always telephone them, and they give us a very prompt response. So this requires internet. So we have fortunately good internet connection here. The other area where we've been using technology has been our medical records. So we have in the field, we have been recording it on our tablets using the Avni system. And in the hospital, we have Bamini. So the two are interlinked. So from the areas, we can get patients' medical records while we're working in the field. And if you have any questions, we can access their records. So that's been a great help in improving care. We've also recently been involved with AI. We have a machine which helps us with peripheral smears. So if we can upload a peripheral smear to a pathologist from a company called SigTuple, they are able to read the peripheral smear and tell us if it's normal or if there are any abnormalities. This has been especially useful where there are certain abnormal cells which we may find difficult at our end to identify. So we have a pathologist look at it, and then we can review the smear with the pathologist. So that's been a great help. So our progression has been quite rapid for the use of technology. As mentioned earlier, COVID has caused the travel to become much less. So Zoom and the other modes, Team and so on, have been used extensively to communicate with other doctors and to have webinars and discussions. For example, many of our hospital discussions are now on Zoom, so that we can do it after hours, for example. We also are getting into learning platforms for our students. So we have a A&M training program here. So we are planning on uploading all our material there so it can be by using this platform. We also have a school, so the school also will be using this platform. So technology really has been of tremendous help in rural areas because it gives us access to consultants. Internally, it helps us with our records. It also, I think, as time goes on, many of the results, pathology slides, and so on can be digitized, and we can get reports much quicker than we are right now. So I think, in all, I think the presence of technology is paramount, is crucial for the advances that take place in rural areas. As far as telemedicine is concerned, we have telemedicine groups, but the problem is that when you have an emergency, it's often difficult to find a person at the other end, or for some reason or the other, the person is not present at that time. So, but the WhatsApp group really, really works very well, and we have many groups now: cardiology, orthopedics, and so on, neurology, as I mentioned. So, all these groups have been very effective because we have consultants at the other end who are very responsive to us, and you, who use this as a mode for their volunteering, their services for rural areas. Thanks.
That's wonderful to know, sir. But these are the successes. But how did you actually get to have this collaborator? What were the challenges in getting all of these people together, and the challenges of actually having this internet connectivity solved, the electricity problem solved? How did you actually go about doing that? How did you overcome these barriers?
Fortunately for us, when we started 30 years ago, we developed friends in various sectors. So we are located in Gudalur, which is in Tamil Nadu, bordering Karnataka and Kerala. So we have links with St. John's Medical College in Bangalore, with Christian Medical College in Vellore. And we have volunteer doctors who've been visiting us regularly for the last 30 years. So we have pediatric surgeons, obstetricians, gynecologists, urologists, and so on. They have all been visiting regularly, and this has been an organic growth. So once internet became possible, all these individuals were contacted by WhatsApp or by email. The electrical situation here has also improved dramatically in the last 30 years. So initially we used to have a lot of our electricity was on generators. Now we use generators only occasionally. Most of the time we have the EB power is there, the electricity power is there, and also we have gone extensively into solar. A good chunk of our computers are on solar because of the fluctuations in voltage. We've switched to have solar for almost all our computers and sensitive equipment so that they don't get this massive fluctuation. So as things have evolved in Tamil Nadu, we have been able to keep utilizing the advances to our advantage. So I would say that we have these challenges, but I think with the opening up of the internet and many of the facilities, the infrastructure improving. For example, we have cable now with a lot of different BSNL, Asianet, and so on providing us with cable. So we're very fast internet. So I think we have been very fortunate in having and accessing this infrastructure improvement. Thank you.
Ma'am, sorry to interrupt. Just wanted to inform that Dr. Lavnish and Dr. Sharma have joined.
Yeah, thank you so much. So that's wonderful, Dr. Nankumar. So that really shows that collaboration is the key to build the right network, to have people.
I am also here now. It has okay.
Yeah, Dr. Sharma, welcome, sir. So we were just having this discussion of how the need to have technology for improving rural healthcare and the challenges and barriers faced to adapt it into the rural setting. So we have been hearing about the perspective from the south. So we would like to know your perspective from the north. What were the challenges that you faced and about your thoughts?
Right. Now this is what exactly is that first thing is what is a surgeon and what is a rural surgeon. Surgeon is a surgeon. He works in rural area or in the urban area. This is one. Two, the patient is same. The patient staying in rural area or in the urban area. But the problems remains different altogether as far as the rural area is concerned or the urban area is concerned. Because in rural area, problem starts with the doctor joining there, with the surgeon joining there, and then there is no place for him to live. He has to live on a rented accommodation or a tent accommodation. That's one. The two, he has in the dispensary, he has no instruments, proper instrument, appropriate instruments, I mean to say. There are minimum equipment even if it is available, it can work, but not even minimum. 3, public expect that surgeon has come, he will do everything for us. Public expectations also increase tremendously. And thereafter, he is not listened in the higher authorities. Nobody bothers about him. One is posted. And even if there is small complication, everybody condemns the surgeon only. Now the times have come when everything falls on the surgeon. So these are the few basic problems in the rural area. And in spite of that, rural surgeons do wonderful work. They give purpose to relief. A hernia is a hernia, whether it is operated in Delhi or by a surgeon in the rural area. A piles are piles, fissure is fissure, cesarean is cesarean. So all these problems are rather same all over. But what we have faced exactly is that authorities are totally unaware of their responsibilities, because they have never gone to the villages, they have never seen the villages, they have only listening the stories from the people here and there, and then they take decision, which is fantastic decision, unbelievable decisions they take. And one of the decisions which they have taken, that is Consumer Protection Act. Now look at the thing, a man sitting in Delhi doing his job, or a man sitting in big institutes, big hospitals, working in a different thing, and a person work, but their question is saving a life. A strangulated hernia comes. What can you do? Whatever little you have got, you strangulate. Strangulation is relieved, patient is relieved. Then they take you to task. So this is the difficulty. Presently, few difficulties which I have, the rest we'll talk after listening to you. Thank you.
Thank you, sir. So, Dr. Lavnish, I would like to come to you. When you were involved in this project where you were trying to bring in technology to the rural areas, what were the challenges or barriers that you faced when you were trying to get in the gastrous laparoscopy specifically?
Okay. Good morning, Dr. Deepa, and good morning, esteemed panelists. Apologies, I just got late because of the OT. I think I agree with Dr. Sharma here. First point, when there will be an emergency, it will be an emergency. So as surgeon, I'm sitting in a urban center, I won't be able to do anything. It is the person which has to do there. You are asking about the challenges. I think the various, technical challenges, and the government is perhaps working on it. So there are various technical challenges, the difficult terrain in the rural areas. Then you have, but I believe the most important, which I echo with Dr. Sharma, is the lack of a trained healthcare staff there. I was checking some data. I will give you some surprise data. Though it is all of 2015 and 18, I believe tremendous work has already happened. It says 90% of the world's rural population lives in Asia and Africa. And number one, the leader is India. 45 million remain in India, followed by China. Then is the Nigeria and Ethiopia. 70% of the rural population, the healthcare, only 34% healthcare staff is there. So I think that is one of the major thing which is lacking. People have to take up this rural healthcare in a great possible way. Dr. Ganraj is going there working. So that obviously means, lack of trained doctors or healthcare staff is perhaps missing. And telehealth, I think, is going to do wonderful, wonderful jobs. Definitely not for emergency, but whatever the daily requirements, daily kind of illnesses. Now that can be easily discussed over a person sitting there and with a consultant at whatever level, at a primary healthcare level or a secondary level, district level, or even more. So these are my thoughts. I will not exactly say that more of a technical, because I do believe government is working, network is expanding day by day, and it is reaching. I have been working in the rural regions, say just for the last 4 or 5 years. But yes, every time I go, I see plenty of poles and so-called mobile towers are coming up. So that means internet reach is definitely increasing. So will be the things will be the technology will be reaching out there with the help of internet only.
Exactly, Dr. Lavnish. Actually, just before you joined, we were discussing the same thing with Dr. Sheila and Dr. Nandkumar about how they have been able to do significantly good work using technology in their areas of work. Dr. Sheila, I would just like to come back to you here. you were saying about the telemedicine services that you are providing. So I would like to know what are the challenges that you faced in terms of funding and also training and retaining the manpower to do this kind of work. Dr. Sheila, are you able to hear me?
Ma'am, we are not able to hear you.
Can you hear me now?
Yes, ma'am.
What in terms of if you take manpower, whether it's urban, rural, anyway, when you have a younger population, you will have to, they will keep moving. They want to learn more. They might, they have their own problems. You know, they get married, get shifted elsewhere. We do have a college like nursing and others and optometry colleges where they do come and join with us. But they stay on for 4-5 years, and after that, depending on their situation, they do change. We do not have like see for 10, very few people are there for 10 or 15 years where you can train and retain them. It's a moving population, and you should be prepared that you take new people, train and go on with the work. That I think every sector in healthcare has to be prepared, whether it's urban or rural. It's a floating population only. In terms of technology, initially we had Indian Space Organization helping us. Later, internet came into play only by 11, 12. 15, 16, it improved. But by now, that is 2020, there's a vast improvement in internet which you can take up. And now mobile applications have also come up. And video conferencing software, now you have a variety. The things which you can use for teleconsultations. Plus, you can share the desktop from here. And as far as images are concerned, storing, retrieval is also important. In eye, we have something called diabetic retinopathy. For this, we examine when we examine the eye, the retina, if there are changes in diabetic retinopathy, we ask the patient to come to the hospital because it's a blinding disease. For that, we have developed machine learning and AI and all that, which can be passed on to the images. We have a fundus photographer there, trained fundus photographer who takes it in the images of the patients, undilated. We do not dilate the patient in the camera. And we run the software also and send both manually as well as this. It is sent to the doctor and proceed with the presence or absence of diabetic retinopathy. This is as far as technology is concerned.
Thank you for that, Dr. Sheila. Next slide, please, Harshini. We have already discussed the challenges and barriers. Just one last point to this challenges and barriers. Dr. Nandkumar, I would like to discuss this with you. I think this retaining manpower, you have found a very effective solution by training the indigenous population there. Would you like to speak a few words on that?
I think, Deepa, that's a very important aspect of our work. Our organization has the vision of having the Adivasis own and run the institutions. So our health system has about 75 to 80% are Adivasis from this area. And initially we had no school, even class 10 past tribal staff that we could take on. So we actually took girls who were just about literate, past class 6 or 7, and we trained them on the job. And as the organization grew, more and more of the children started finishing high school, 10th, and then we were able to get them into our BSS course. This is a Bharat Sevak Samaj course, which is actually rolled out by the government of India, started by Nehru for rural people to gain access to training programs. So the BSS was our first step in that direction. So we had lab technicians, pharmacists, and so on trained by using the BSS course. Now we have moved on. Many of our Adivasis have now finished 12th. So now we have a A&M program, and the girls who are passing out from there are joining the hospital. So we have been able to retain our staff. The staff the first batch of 8 people who we selected are all with us except for one. So we've been very fortunate to have the same people continue on for many years, for 32 years. And we've been able to, given large, the inputs that we give and the kind of relationship they have with the people is certainly an eye opener. They know every person in the villages. So we have 8 area centers with 2 public health nurses now, and they know the patients individually. So we've been able to do that because of our tribal staff. They know the people, they speak the same language, and this has been a great step in making sure that the program is sustainable and that it continues to grow in that fashion. So our institution has grown, and new departments are added as we get new trained tribals. For example, we send them out for training for various courses, pharmacy. Recently, someone has graduated from TIS with an MPH. So they're now gradually moving on to higher and higher levels of education. One of our tribals has just joined a dental college, no less than the Madras Medical College. So we have been fortunate. I think this is definitely a very important part of retaining. As I mentioned earlier, people leave if they're not from that area. So the challenge is to provide training for them so that they stay and to have a career advance. Here, I'd like to ask Deepa. She had mentioned modules. So one of the things is the growth of the staff, especially the doctors and so on. They are there courses that they can join which are certified? Because in a rural area, one of the problems that you face is to keep in touch with what's happening. In an urban area, there are many speakers coming and having many discussions, and so many lectures are being delivered. But in the rural area, that's a problem. You can have webinars, but I'm just curious to find out, are there any government certified programs that the doctors in rural areas can join, at the end of which they get a certificate saying that they have adequate training for various aspects of medicine as well as the allied fields? Thank you.
Yes, sir. Thank you for that. I guess regarding the courses from the government, I'll need to do some more work on that to find you the exact courses. The modules that I was talking about, we were introduced to this during the conference. This is the virtual reality in medicine. These are all available online. And what is needed for them is to basically to buy a 3D kind of there is a headset, which is not very costly. And I can connect you to the person who is actually doing that. So then once you have that headset, and you can watch these modules, which are all online and available for free. Regarding the certified courses, we'll need to find out more about that.
Dr. Deepa, can I come in here?
Yes, Dr. Lavnesh, please.
Dr. Nankumar, good morning. Since you have just asked about the courses, I will just like to throw some light on it. There is a portal called by the Government of India, which is known as a Swayam portal, NPTEL. And in collaboration with ICMR, they have created some courses with many other universities. Now, it is not just limited to medical. Somebody is interested in, IT, engineering, they can enroll. And after a stipulated time, there is a minimal fees of 1,000. And you can give the exam, you can get the certificate. So all the modules you can do only online. Only for the exam you need to go out, and at whatever center which you can choose. So that is number one. It's totally free. Only for the exam there is a fee. Then whosoever wants to learn, there are plenty of online platforms offering free courses. I would name few, and they only charge in case you want a certificate that you have done a certain training. Coming to number two, WHO runs a huge program, MOOC, which is known as Massive Online Open Courses. Of course, there's a certificate courses that whatever training in infection control or basic, sanitization, prevention practices, maternal child health, you can do. Then Future Learn, Coursera, there are plenty. So, but they charge. Free, they give certain courses, and these courses are perhaps recognized or tied up with big institutes. There's a course of analysis with John Hopkins had run, and the fees is only for certificate is around 2,500. So those who want to progress, they can keep on abide with this information and the certificate also. Thank you.
Thank you so much for that, Lavnesh. That's really So good information to have. Yes. So next slide. So sustaining manpower, we've seen how it can be effectively done by taking the community as a whole and moving together and working towards their progress. How do we sustain the technological advancements in the rural areas? So Dr. Sharma, you have been an innovator. You have brought about many innovations in your area of work. Can you let us know or throw some light on how you have been able to sustain it?
Yes, that's a very pertinent question you have asked me. I had suggested in one of the books I've written, why do doctors avoid villages? This is one of the books, booklet. This is a small booklet which I have put in everywhere. Problem is first going, as I've told you, once you go there, I have already predicted every 3 years there should be 3 months refresher course for each doctor, each surgeon who is working in a rural area, so that he keeps in touch with the latest development in medical science. Seeing on the TV or videos and laptops is different than seeing actually on the patient being operated. So that is the main thing, that unless you keep the doctor in touch with the rural, with the main institutions 3 months after every 3 years, not a bad thing, and again he can go there if he likes it. So that is number one. Number two, during the training, what should be given, what training, minimum training should be given to a rural surgeon? One, surgery, of course, he will be. In associated with gynae also, we have to work gynecologist also. We have to work as an anesthetist also simultaneously. Simultaneously, we have to work as a children's specialist, and simultaneously we have to work as a ultrasonologist also. These are all 5 in 1. We have worked in saving the life in emergencies. We have done it. Unless we are trained, or anybody is not trained, he can go for 1 month course and he should be sent whenever he likes to go. So this is how we can keep in touch, and then we feel honored that we are part of the medical college or teaching institution, big institution, and they are serving people, we are also serving people. Purpose is same. So the purpose is of training the people at particular point of time. That is one. Secondly, feeling the difficulties. You have to send a paper to the government. Nobody will listen to the paper has come from the rural area, forget about it. In secretariat, nobody bothers about it. Bureaucrats don't bother about it. And above all, you have got this new act on your head. This is a new act on your head. That if you commit a mistake, you do this thing, you do this thing. If there is anything, that you are a Consumer Protection Act under, you will be taken. So first thing is first, doctors should be sent for the training every 3 years, come what may. 2 to 3 years, 1 month, 2 months, 3 months, whatever they think proper, but where in whichever section he likes to work. That's one. Second is, his papers should be given preference over others, so that he is working in a rural area. He cannot come every day and night. He has not to get rid of leaves. His leave is gone also. So these are few basic points before, and then whatever you see, most of the research has been done by the rural people. Most of the research has been done by rural, not big laboratories. I can still say Dr. Javle, he has got 101 patents. Nobody in the world has got 101 patents, but he is the only doctor in the country itself. Have we recognized him, his services? No. So let us get large number of surgeons, large number of doctors have done something new because they need it, for which no availability is there. I didn't have a retractor. So how to do a hysterectomy? So I devised a new technique of hysterectomy, 3 stitches on right, 3 stitches on left. So not availability is not a bad thing, but you should be creative also simultaneously, and you will do something new. For this part, I convey this much only first. Thank you.
Thank you, Dr. Sharma. Next slide. With all the discussions, it's definitely, this question is no longer relevant. Technology is definitely a boom and it's not a burden. The reason for putting up this question here was regarding the maintenance of any kind of technology which is coming into the rural healthcare. Do we have adequate support for the maintenance of the equipment, or for the regular upgrading the equipment? So this is something which I would like to ask Dr. Sheila and then Dr. Nandkumar.
What you have said is very true. Is technology a boon? when you want advancements in technology to be implemented in the rural healthcare, you need money to support it. You need some kind of donations to have it brought in. And then sustainability also, because as you need to sustain, every year there is a cost to it, added to it. But definitely technology has to be implemented. When we started, as I said, we started with Indian Space Organization. Then we shifted to internet. And again, internet, you have to pay an initial fee and then recurring costs are there to maintain the internet. And then when the hotspot came, we shifted to hotspot. We were able to connect many of the computers to do our EMRs. So that again, it came at a cost. Initially, we used paper. Then we shifted to electronic medical records. When we shifted to electronic medical records, again, a cost was involved. Initially, it was paper cost was less. When you want to implement EMR, you need computers, you need laptops, and then people trained to use the EMR functions. And then you need technicians to take photographs, to upload the photographs. And then all this needs another thing, which is storage. Whatever you do here, now storage becomes a problem. And everything is, storage again is at a cost. Then the next thing is whether we can see the EMR directly from sitting at the base hospital, whether we can view the EMR in the computers, or that has to be sent by some other technology. Whether it's an offline EMR, online EMR, again, cost is involved in it. As the years go by, new technologies, now mobile phone has become very, very, almost everyone is having it. So we are now trying to take it from laptops into mobile phones. Only thing, the feeding in screens are small, so people have to get used to it. Images also, clarity of the images is much better than in a laptop screen. It's much easier also sending images, receiving images and everything. And as a learning thing concerned, initially you started with classrooms where the teacher and the student were there. Then we went into virtual classrooms where the teacher was elsewhere. And then during the COVID times, it helped a lot. The students could be at home and still learn. And now we have come into many modes where virtual reality also can be used. So every technology which comes in is very useful in the rural technology, rural healthcare setting. But again, it's at a cost. Because for the rural patients, you have to, examination is free, surgery has to be made free, and all the technological advancements which you are doing, again, has to be made free. There is no money which is coming in, or very minimal which comes in to support the technology basis. So taking all considerations, it's better to implement it and know the cost involved as well as the recurring cost which is involved.
Ma'am, sorry to interrupt. I just wanted to let you know that we have 5 more minutes. If we can wrap it up around 11:20.
Yes, I am aware of that time. I'm sorry, it's overshot a bit. So maybe we'll go to the last question and just take a take-home point from each one of the panelists on how can we better integrate technology in rural areas. That is from what is already done, what else needs to be done according to them. So Dr. Nandkumar, shall we start with you?
I think internet connection is one of the things which needs to be improved, and I think the government has been doing as well as private players. So that's one area. The second is that we need more people, as Dr. Sharma has mentioned, more people in rural areas. And one of the things that we've started is a website called ruralhospitalnetwork.org, where the vacancies in rural hospitals are being posted, and this is a free website. So we need the postgraduates to see the vacancies in the country, right across the country, and actually come and serve there, because there's a huge need in this area. So technology can only be implemented if there is someone on the ground who can actually provide the services. So I think that's probably the most critical factor, apart from, as the previous speaker has mentioned, finances. So it's always a job trying to get finances to keep all these donations, to keep all the work going. Thank you.
Yeah, Dr. Baines, can we have a take-home point from you?
Okay, Dr. Deepa has already pointed out, I think the cost is more of a, organizational barrier, and then it comes to time. When the initial, absorption of the technology is there, there should not be no stressing for the healthcare workers. That needs to be taken care of. It needs to be, I think it's already on the move. Yes, it will lead to, better working. It will be definitely reduction of their time in the longer term. But I will stress upon this, we have two of the pioneers already sitting, and all of the pioneers here. We need local champions, actually, more of local champions. Now, Dr. Nandkumar is in one area, Dr. Sharma is in one area, ma'am is working more in telehealth. But we need more of local champions to take up these all kind of leadership roles. And government, rather than pushing for this some kind of a posting rural, they should have more incentive. They should have a long-term commitment with this long-term investment for this rural healthcare. Okay, identification of champions is pretty much important, that I believe.
Thank you, Dr. Lamnesh, for that. Dr. Sharma. Dr. Sharma, are you there? Dr. Sheila, maybe we can come to you and then go back to Dr. Sharma. So can you just let us know one takeaway from this, what further needs to be done?
Each time when a new technology comes, it's very useful to implement it in the rural areas. What we realized is cataract surgeries, we used to bring the patient here and get it done. Later, the innovation was done with the help of HTC. We developed a mobile van, and patients' surgeries could be done at their doorsteps. But again, this involved a cost, and we needed doctors to go there and get it done. So it involved people to be committed to that cause, and of course, donations to support it.
Thank you, ma'am. So I guess this cost is coming up in a multiple number of times. So, and I guess our government is doing quite a few things. So maybe we have to have more interactions with them to try to find out what are the different schemes available, what are the support mechanisms available. So I guess HTIC is something who can help us collaborate with them and take us forward with there. Is Dr. Sharma there? Harshini?
Yes, ma'am. Dr. Sharma, we are not able to hear you.
Can you hear me now?
Yes, sir.
Yes.
Yeah.
So what I was saying that first, the people sitting in big cities should not think that the person in the rural area, they are not doing anything, they don't know anything. This is general thought among the people sitting on the high posts. And we have got excellent ideas, excellent thoughts, and excellent work, and excellent research work also. There is no doubt about it. The rural people have done wonders all over the world. Now, I'm not talking about this country, particularly in India. They have done wonderful works. So let us recognize them also, and similarly put a channel there on which if you do something new, you put up that channel so that youngsters also know that while doing a rural area, we can do this much. Right from head to toes, all types of surgeries people are doing to save the lives. So total purpose of medical profession is to save a life, to give a relief to the person, whether it is roadside, small abscess, or a big surgery. So all are same. There's no problem in that. So what I'm saying is, it is a coordinated efforts. Rural surgeons are doing wonderful work in this country, but only thing is they need a patting from the higher authorities who are so-called patters, even if they don't have much knowledge about it. They should listen to the people and implement. And what we are doing without no expenses on the government side. Minimum expenses with minimum equipment, and wonderful surgical procedures are being undertaken. So only thing, recognition. That is one point of it. Rest we'll talk subsequently.
Thank you so much. So to conclude the session, I guess all the panelists with their rich experience has brought out few important points. That is to have a transparent portal so that there is a good rural-urban connect to know what is happening and what is a reliable technology which can be utilized, to have that open channel of communication, to have adequate training support to the surgeons who are working in remote areas. So with this, I would like to hand it over to Harshini. Thank you, panelists, for your valuable time. And I'm sorry that we overshot it, but it was a really interesting discussion.
Thank you.
Thank you.
Thank you, Dr. Deepa, and thank you all the panelists for joining us today. It was a great, insightful session. Hope we've got a lot of information about technology in the field of rural hospitals. Thank you so much, ma'am.
Thank you. Thank you very much.
Thank you, ma'am. Moving on to the next part, we have with us Mr. Purushottam, CEO and founder of Deep Vital Private Limited. So it is a startup demonstration. Purushottam, I'll be sharing the screen for you. Purushottam, we are not able to hear you. Your audio is not connected. Yeah. Can you hear me now?
Yes.
Yeah,
Yes.
I'm sharing the screen for you. Please go ahead. Can you hear me?
Yes.
Yeah. Can you hear my, can you see my screen?
No.
Purushottam, you're not audible. You're not audible. Yeah, your audio is not connected yet.
Hello. Hello.
Yes, sir. We are just trying to get the next speaker in.
Right.
Purushottam, you're on mute now. Okay. I think he has some network issues. Meanwhile, we'll just move on to the next part of the session. So next we have with us Dr. Abhijit P. Deshpande, Professor at Department of Chemical Engineering, IIT Madras. Dr. Abhijit is a professor and his focus is on obtaining the understanding of polymeric systems, more specifically their aggregation and gelatation behavior. Rheology is used as a probing tool to investigate polymer bends, sulfonated polymers, cross-linked hydrogels. So his teaching interests include specialized courses in fluid mechanics, rheology, and continuum mechanics, and core chemical engineering courses such as mass transfer and thermodynamics. Happy to have you with us today, sir.
Thank you. Can you hear me?
Yes, sir. Please
Okay.
give me a minute. I'm just sharing the screen for you.
Yeah. First to just say that I'm not going to talk about all of the things that was said regarding the introduction because I'm a faculty member in chemical engineering. But in this forum, I have joined as faculty in charge of Rural Technology Action Group. So this is a group which is at IIT Madras for last 15 years. And we work in domains of rural technology. Can we just have it full screen?
So it is on full screen only. Since it is in PDF, this is how I am able to view it.
Okay. If you say Control L.
1 minute, sir.
Oh, you're opening it on a browser. Okay, let it be. It's fine. I guess it's visible enough. So Rural Technology Action Group, as I mentioned, has been there for last 15 years, working on several different domains of problems. As the byline says, technology solutions for need-based identification. Specific role of RUTAG is to be connected with rural areas through NGOs, through individuals, through our own contacts, let's say of faculty and students. And from time to time, we organize workshops, we organize brainstorming sessions and so on. And if a need is identified, then we try to get IIT Madras faculty or students to try to seek a solution to whatever is the need that has been expressed. So I'm not, I have no experience in working with health hospitals related problem. So most of what I'm going to say is going to be useful only from the point of view of generic context of rural areas, which also was discussed over the last panel discussion. And so some of those points you may see them highlighted by way of specific examples that I'm going to just talk about. And the way I'm going to make some of my points are by just going through, what we do and some of the example problems that we are working on. And when we have these specific problems, what are the roles associated with entrepreneurship as well as employment opportunities in many of these problems. So that's how I have structured my presentation. So we can go to the next slide. To start out, actually, it's little. Can I project it from my side or no? You have not enabled. I can share. Is it okay if I share?
Yes, sir. Sure, no problem. I'll stop sharing.
It may be just easy. Just give me one moment. Yeah. So I'll share my screen. Can you see the screen?
Yes, sir.
You can, right?
Yes.
Yeah. So as I was saying, is I'm just going to talk about few of the problems that our group has worked on in recent times, and in which way do we feel the role of entrepreneurship or employment opportunities can be sort of increased. So by way of some of these case studies, I'll be quickly giving you some of the pointers. Feel free to stop and question me in between. Before I proceed, there's just one thing that I wanted to check here, Harshini, and who is the audience here? Just to confirm again.
So this is actually being telecasted on iConnect. So it is one of the 75 events of the DBT that is conducting.
Right.
So it is being telecasted in a separate portal. This is the one where speakers have joined. So
Panel.
if there are any questions from the audience, we'll get it from them and we'll
Okay.
share it.
Yeah. So if there is a question in between, also please feel free to interrupt. I can clarify as we go along.
Sure,
Okay.
sir.
Okay. Yeah. So I just wanted to sort of talk about rural technology in some of these phrases that are being used to look at what the Indian scenario is, and many of these have specific role for technology, whether it's to do with self-sufficiency, whether it's to do in promoting startup culture, or whether it's to say make it in India. All of them have a technology component. And of course, we as an audience would like to, ask the same question in terms of rural technology in the ecosystem of rural areas of India. And as was mentioned also earlier in the panel, that rural tends to also encompass peri-urban areas and also socially impactful interventions in say, suburban areas and so on. So it's a broader definition with which we try to approach the issue of rural technology. And the RUTAG, Rural Technology Action Group model, specifically tries to work on first by looking at demand-driven technology solutions. So as I said, since we keep our ears to the ground, so to speak, we are able to connect with NGOs, individuals, local government officials, and that's what we call a demand-driven sort of idea. And this can probably need, so focus here is on an individual problem, because somebody says, I need a de-weeder for a crop, or I have a lot of production of certain seed, let's say neem, and I want to be able to make oil at a small scale instead of selling the seed to some aggregator. Can I have more increased livelihood locally? So can I get a small scale oil expelling machine or oil extraction machine? So these are all sort of demand driven technology solutions. And focus here is, of course, the individual problem itself. And then sometimes one can look at mission or a thematic excellence where the focus tends to be a little larger. And we can try to look at problems in a more generic manner, and also have a spectrum of solutions within one specific product. And what I'll do now on the next slide, it's a slightly busy slide, but it talks about some of the problems that we are currently working on. And each of them have issues which are related to livelihoods, improvement in rural area. In each of these, we are making a technological intervention, but each of these has a lot of challenges in terms of entrepreneurship or employment, later on. So if you, let's say, look at this example of pottery. So pottery, of course, has been practiced as a craft and artisanal output for centuries. And in the change context of competition from various different materials, pottery still is in demand, though in much more of a niche market. So one of the technological interventions that we were able to do in pottery was to create microwavable pottery, so that you can have the earthenware appeal that's associated with pottery, but at the same time a use which is fairly modern in terms of being able to heat food in microwave. So now the question here is as to what's the, how do you have an entrepreneurship based on this? Because the pottery technological inputs, traditional inputs are spinning the wheel and clay and many of these things, which happen to be low capital intensive. But once you say microwavable pottery, now you move on to ovens, because firing temperatures change and the control on the clay formulations change. And so now it gets taken out of the low capital investment kind of a model. And so now how do you encourage entrepreneurship in this kind of a scenario? So to begin with, the model that we have right now set up is more what's called a common facility center. So many of the problems which are where the technological interventions we are making are for artisans, and that to traditional and historical artisanry, then the model that is generally chosen is basically a cooperative model. So in the sense that a common facility center where either with the help of government or with the help of corporate social responsibility type of funding, we generate a common facility center which can be used by entrepreneurs and traders and people who are themselves making pots for livelihoods and further trade. So this is how highly capital intensive technologies can get penetrated, because otherwise it becomes very difficult with the scales involved, and with the other idea also is to still keep humans involved in many of these things. So pottery, for example, we know we have ceramics pottery, right? Ceramic ware, which is all molded, which is all automated technology. And so one can, of course, go to such technologies, but then you completely eliminate the artisanal skill set as well as involvement. So many of the work that we are doing is a mixture of the two, where we are trying to bring in technological intervention, but still keep the artisans or humans which are in the rural areas, their livelihoods in mind. So one of the other project that, for example, recently we've done some work on is a smart lighting system. One of the other thing that I should say is, though I am presenting, actually I'm presenting all of this on behalf of faculty and students who have done the work. So since I am in charge of this Rural Technology Action Group, when I say we, it's actually the work quite often being done by faculty members or a group of faculty members. So for example, in case of smart lighting, it's a Central Electronics Center at IIT Madras, which did the project, where we are trying to figure out if this is related not so much of lighting itself, but what if a light goes out and it has to be replaced. So trying to figure out in far-flung areas whether a street light is working or not. And the easiest solution is, of course, to say that, you put a sensor on each and every pole where the street light is, and that's a prohibitively expensive solution. So then can we do something which is affordable, and also can it generate livelihoods beyond the technological solution itself? So in this case, for example, what Central Electronics Center came up with is a small box which can cost around 1,500 to 2,000 rupees. It tries to measure current and voltage, not in one single pole, but a collection of poles. So maybe about 15 street lights can be measured. And if by measuring current and voltage, we can try to figure out if one out of those 15 or two out of those 15 lights may or may not be working. And so now the 2,000 rupees box can also be assembled locally. So we can not only provide a solution, which is, and this problem came from basically collector, erode collector. And the overall framework also was provided by the collector, where they said that, if you can make the box locally using self-help groups, then it will be really interesting. So this is the way in which a technological solution which is generated, but then you think of, providing more scope for entrepreneurship and employment locally itself. One of the recent projects that we have been doing is on vending carts, and this is related to basically fruits and vegetable carts, but try to add on value by various ways, in terms of cold storage, in terms of maximum display area, in terms of stability of the cart itself, and looking at is an all-weather cart, and so on. So adding many things which otherwise may have been missed out because of the nature of the industry. Vending cart industry needs to be very, very localized, and it is also a lot of tinkering that happens. And so by incorporating some of these as modular solutions, then this local production people can then start incorporating these modular features into many of these carts. One of the main projects that we've been involved is related to grass weaving, which is basically Pattamadai mat. Many of you may be familiar. If not, you can look at it. It's been in news for various reasons. It's, of course, a heritage product from Tamil Nadu. Just last month, Chief Minister Stalin inaugurated the center in Pattamadai, which is established using technology given by us. And it was also in the news couple of weeks ago, because Prime Minister Modi, one of the gifts that was given in Japan was based on this Pattamadai grass weaving. So it's a grass weaving mats, basically, which are used, chatai or pai, as they are called, all over India. And this is a craft which is practiced throughout India. And again, it tends to be very artisanal and associated with certain communities who do the weaving. And of course, livelihoods have become more difficult with the wages not being as high as they can be. So some amount of technological intervention can help. And based on our intervention, actually now a mat which used to take 10 days to make now takes only 2.5 to 3 days. And this is still being done manually, so it's still within the focus of handloom, but we can do a lot more in terms of patterns and so on. So that's another way. So you can see that whether it's the vending cart or whether it's grass weaving, we are looking at not just one single problem, but multiple. One way in which now grass weaving we are expanding is to also take the knowledge that we have generated from Tamil Nadu example and see whether grass weaving that's done in West Bengal, can our technological intervention help there also in terms of mats which are called Madhurkati mats. And so this is how again you can go from one area to another, again keeping in mind the use of technology, but eventually hope is that this use of technology will lead to more entrepreneurship opportunities locally, and also will lead to more employment possibilities. How am I doing with time?
Yes, sir, we have 5 more minutes.
5 more minutes, right? Yeah, so I'll try to wind up in these 5 minutes by just sort of highlighting that. So as I said, the Common Facility Center is one of the ways in which we go ahead, and many of the topics that I talked about, whether it's pottery or whether it's grass weaving, we have done the Common Facility Center. But there are some individual products which are based on demand-driven technology. We are trying to do a startup or a product, and so that's how the overall activity has been going on. In many of the cases, if you look at, let's say, one single product like a groundnut pod separator or a mango decorticator or a paddy thresher, each of these is one single product, and it's very difficult to figure out an entrepreneurship model which only has one particular product of this kind. Generally, companies which sell, let's say, agricultural machinery will have a spectrum of products, and one, of course, issue associated with many of these products is the fact that they need very local context. They also are very scale dependent. So if for let's say 20 acre and above land holdings, there is one set of machineries. And for very, very small land holdings, of course, labor of the farmer plus a few other labors is basically the only solution. But what if your land holding is 5 acres, 3 acres, 7 acres? Then the machinery sometimes is not optimum. Labor availability on the day when you want is again not really always there. And so there are various demands for these kind of technologies which can help. And one of the things that we've been also working on is a way of trying to figure out how to get many of these implements done locally. And so we are trying to create a resource platform which we call Crossfire, and the motivation for it will be based on basically any time when you go to a YouTube, and this is, for example, some mini trailer YouTube which is there on and then if you look below YouTube, you can see, of course, appreciation, but tell me the price of the vehicle, there's some technical question, where is the braking system? So there is, in general, that there is a lot of innovation happening locally. Many of these things are getting fabricated locally, but if you look at the broader picture in terms of its demand everywhere, there is, of course, a lot of demand everywhere. And so can we do something which is more than what YouTube does? So YouTube basically can just provide the information, but can we also have technical know-how, dissemination, maintenance, and servicing? So we've been trying to work on a resource platform which can be aggregator, and we call it Crossfire. So where the idea is to sort of provide the design for local manufacturing. And we have a set of machines, and we can basically, who can make a machine also can enroll, and those who want to purchase such instruments can also be part of this network. And this is mainly associated with fabrication, machining, so mainly mechanical, electromechanical, electronics, electrical, those kind of implements. And so, for example, there are these, I mentioned about vending cart. This is a hand loom which is used in grass mat weaving, the paddy thresher. So we have videos which are fabrication videos also. We have specifications, cost of different components, also designs, 3D designs, 2D designs. So that using all this information, you can actually locate a fabricator and then try to make the machine. So that's basically the idea of this platform. And so in summary, what I've tried to do is to sort of give you an overview of some of the projects that we have done, which include basically demand, which is generated at a single source, as well as thematic and mission mode. And generally, the model is related to common facility center or incubation. But given the overall context and the kind of ecosystem we have, we really need work on all different fronts for us to really go that extra distance of having entrepreneurship based on these kind of technological solutions, or having more livelihood or employment associated with these solutions. So with this, I'll stop. I'll be happy to answer if there are any questions.
Thank you so much, sir. Thank you for your great presentation. Hope we might have got good information from your slides. Thank you so much for joining us today. So if there are any questions from the participants further also, we will share it with you on mail, and
Sure.
we will send them back your answers.
Okay. Thank you. Thanks a lot. Thank you.
Thank you so much for joining us.
Bye.
Bye. So next we have with us Ms. Nidya N. Johi, founder of Spot.Bio Innovation. She is here to give a startup presentation. Over to you, Nidya.
Am I audible?
Yes, you are. I'll just share the screen for you.
Sure.
Please go ahead.
So good morning, everyone. I am Nidya, founder of a startup called Spot.Bio Innovations, which is incubated at HTIC MTI, and Byrod's first fellow of previous cohort. So I present here one of the projects at Spot. We are developing a point-of-care electrochemical immunosensing device to measure the levels of a serum biomarker called placental growth factor for improved preeclampsia screening at resource-limited settings. Next slide, please. During my Byrod's first fellowship period, we underwent clinical and rural immersion across the country to understand various unmet needs in maternal and child health. So the problem that we have chosen particularly is preeclampsia, which is a pregnancy complication characterized by newly onset hypertension and end organ damage, and could result in seizures and death if left untreated. After the onset of the disease, termination of pregnancy is the only cure. So early screening and continuous monitoring and timely clinical interventions are required to prevent any adverse outcomes associated with preeclampsia. If we look at the disease burden in India, the incidence is 2 to 27% and is responsible for 12% of maternal deaths and 40% preterm deliveries. And also the burden is shouldered by women in rural and tribal areas. Next slide, please. We looked at the current screening methods in urban and rural areas. Clearly, there were unequal distribution of health resources. So in rural areas, there is no early screening for preeclampsia. No such screening is performed in the first trimester. Whereas in urban areas, there were preeclampsia screening solutions available in commercial diagnostic labs using a prediction model, which is a combination of maternal factors, mean arterial pressure, ultrasound marker, and a biochemical marker.
So when we look at the feasibility of adapting this in the rural settings, the first two could be performed at low resource settings, the maternal factors and the mean arterial pressure, whereas the other two were specific markers that are not amenable to widespread use because of their operational, logistics, infrastructure and cost issues. So we found that just addition of a serum biochemical marker to the simple maternal factors could improve the detection rate by 20%. And so we look for alternative solutions to measure the serum biomarker in areas that are inaccessible to sophisticated biochemistry labs. Next slide, please. So we are developing a point of care device that measures this particular biomarker, and we hope to align it with WHO assured criteria, which stands for affordable, specific, sensitive, user-friendly, rapid and robust, equipment-free and deliverable, so that it could be used in low resource settings. So this is not a replacement for an already existing very good solution, but this is a replacement in a place where there is no solution at all. So the device consists of disposable strips which are made of screen printed electrodes, functionalized to detect picogram levels of the biomarker which are in the clinical detection range, and a very compact USB potentiostat that could be plugged into a mobile or a tablet, and a software that analyzes and displays the values which are user friendly to interpret, which is more or less like a glucometer which is in the market now. The next slide, please. So the work is still in progress and yet to be validated, and could be integrated with other clinical factors to come up with a prediction score that can help in improved preeclampsia screening in a PHC or in a low resource setting. We believe this would improve the accessibility of biomarker-based preeclampsia screening in rural settings, and this would also help in making a technology roadmap for such electrochemical immunosensor-based devices that could be developed for many other biochemical tests that are not accessible to low resource settings. So that's all from my side. Thank you.
Thank you, Nidya. So next we have with us Mr. Purushottam. Yes, he's able to join now. I'm just sharing the screen for you, Purushottam.
Yeah, I hope all is perfect now.
Yeah, it's perfect.
Yeah.
Just a minute, I'm sharing.
Yeah. So before sharing myself, I'm Purushottam, founder of Deep Vital Company. I'm currently situated at IIT Madras Incubation Cell, and which is associated with the Healthcare Technology Innovation Center. We were recently recognized by the Startup India and Startup Tamil Nadu. Next slide. So the problem which I got it through this, like I have done the first fellowship on mother and child health. So one of the incidents which happened to me is like in the primary health sector, where like mother came to the delivery room and found to be that the baby was resuscitated. And finally, like doctor took a consent from the patient saying that we cannot assure the baby for the next 48 hours. Then finally, we found the baby as aspirated and found with sepsis and aspiration. Then we saw that like what are the factors which is associated for this not having a differential diagnosis. Like one of the problem is like the meconym chain amniotic. So simply to put that, like meconym is the first to the baby. Usually it passes after the baby is born. So if what is inside the baby, so that is usually called as meconym aspiration. If you're not able to detect it properly, if it is inside the womb, it leads for aspiration. And the sad part is like it happens at about every 10 newborns in the lower societies, which is very high prevalence, which will be less prevalence in higher resource settings, and where like they have the adequate equipment and all. But the problem is lies at the lower resource setting where it doesn't have anything to be try to detect this as a early marker. Next slide. So to know that like what is the factors associated with during the fellowship, I have visited a couple of hospitals to know what is exactly that happening. And this is the hospital we were visited during our fellowship program. Next slide. And like to put like the clinical aspect and technical things, so we wanted to design a device where you can able to identify price so that we form a team with the clinical and the technical board. Next slide. And this is like what we are actually trying to do is like we want to know what is actually properties of the tissue of the mother so that we can make a device so that it could able to identify before the baby was born. That means like when the mother comes to the labor room. And also we were identifying like what is the properties of the beacon so that we can identify respective directly to device that the property and the amniotic fluid passes into the the meconomies passes into amniotic fluid. Right away it will give the information to the obstetrician to triage and make. So this is a back science we are actually trying to make in a proof of concept. Next slide. This is an initial prototype, or not an initial prototype, but like design looks like where you have an opto model where you are actually placing this as on the top of the tummy. So it will have the light sources which will inject on the time manner so that it will try to detect the mechanism when the if it is passes in dominantly. Right away it will convey the information to the patient like whoever wanted to know about this problem at the early stage so that they can refer the patient at the high risk settings where the resuscitations are very available. Next slide. So we are actually bringing into the novelty and IT starting and feasibility into the system so that we can have a better quality and better identification system where we can give exactly the point where the mechanism happen directly to the caregiver. And the next slide. And this is like we named the device as a magnet, so it works basically like light with artificial intelligence based, where we are trying to put the light into the top of the tummy so that we can directly have that like when the mechanism is there, it will try to produce a different concentration level that we can use artificial intelligence to have a signal process to process it and give a early detection to the future who actually wanted to know which are the population which goes for the mechanism so that they can refer early stage. And it's a confirmation device. That's like where we're actually pitching on. So existing devices doesn't produce the results which give the accurate results and exclusive for the mechanism detection. So this device will actually make sure that like it can properly detect and not give any. And also is used for the referral centers also for a timely intervention. And this is to put the translate area. We actually formed a team with that, and we have the clinical partners also. Next slide. Next slide. And this is India, where actually we are targeting the 28 million deliveries very happily. And the competitive advantage where we have is like we don't have any device on the commercial aspect for right now. And India report, we have the people like ultrasound, those are like producing ultrasound. And we make sure that we produce a device which has a high accuracy and sensitive enough to pick the meconium at the early beginning itself so that they can have a triage and referral the patient up to the nearby facility center. Check on slide. And this is our target customers and revenue model we put forward, like so that we can have a hardware and software device into that. And we priced into the way that like the 20,000 for the device at the initial cost. We haven't. That is a like basic approximation we had done, but let me tell you over the period of time. Next slide. And like as I said, like we actually I was graduated from the Biorex first fellow, so we got a grant, and right now we are actually working from the grant from the negative trials to develop the prototype model from the proof of concept we are actually currently working on here. With that, I'm thanking for the actually to give my time to present my idea. I'm happy to take your questions in offline or online if you prefer me to say. That's all from my side, Ashwin.
Thank you so much for joining us today.
Yes.
So moving on, we have with us Dr. Jnanaraj, Secretary, International Federation of Rural Surgeons, past President and Association of Rural Surgeons of India, founder of Rural Surgery Innovations. Dr. J. Jnanaraj is an accomplished urologist and laparoscopic surgeon trained in Christine Medical College, Vellore. He has been working in rural and very remote areas of India for 3 decades, has performed or been directly involved in helping others perform thousands of surgical procedures in rural areas, and has helped more than 30 hospitals start minimally invasive surgery devices. He is a past president and project lead for the project guilds of the Association of Rural Surgeons of India, the secretary of the International Federation of Rural Surgeons, and board member of the T4 Alliance. He has many innovations award like the EHA Innovation Award, Anshiya Princess Award, the Lockheed Martin Award, the Millennium Alliance Award, etc. He has few patents and low-cost equipment is listed in the WHO Compendium of Medical Equipment for Resource-Poor Settings. Dr. Jnanaraj has been the president of the Association of Rural Surgeons of India and is the secretary for the International Federation of Rural Surgeons. Happy to have you in this place, sir.
I understand that technical thing. Just want to start by sharing how we became involved with the devices for rural technology or rural surgery. In Northeast India, we have a lot of patients who are in end-stage renal disease, who needed dialysis or renal transplant, both of which are very expensive and not affordable by the rural patients. Okay, so there was a little technical problem saying that it is not audible. So when we have patients like that, we do what is called peritoneal dialysis, or put a tube inside the abdomen and to carry out the dialysis, which the patient can do at home. And many of them are quite happy with it. But the problem was that these tubes are very expensive. The tubes which are produced by Baxter cost about 13,000 rupees. And they used to get blocked after a couple of weeks. So I went to Coimbatore and asked the engineering college in Karana University whether they can make a similar tube, because it looked like an ordinary elastic tube with many holes. So they took me to the industry. So when I went there, they said, how many tubes do you want? 1,000 or 10,000? I said, no, we need only 10 or 15 tubes. Then they said it's very expensive if you need, but if you can order in bulk, we can make it cheap. I said, how expensive? They said it'll cost about 600 to 900 rupees because you're ordering only 10 tubes. Then I realized where is 13,000 rupees which Baxter charges and 600 to 900 rupees for locally producing it. Then I asked them, can you make a catheter with the memory, which you can straighten it out to release the additions? They said that is possible and it will cost another couple of hundred rupees. And then we made a tube.
He's the one who's like, we should go after his agents. So he kind of spoke on my behalf. But he also told like, so like when he started.
Okay. Okay. Sorry for the interruption once again. And so we're going back to medical devices which are necessary for rural surgery. You need to realize some of the background that while WHO recommends 20 to 40 surgeons per 1 lakh population, we have only about 2 of them, or much less in some areas and rural areas. And how do you take modern surgeries to these places? For example, the first place where I worked in Dance districts in Gujarat, for a population of 3 lakh people, there was not a single allopathic doctor. Then we went to Arunachal Pradesh, where we had to drive for 17 hours and walk 10 hours uphill to reach a place where about 4,000 people were living. And most of the places in such remote areas, we had to drive through mud and rivers and so on, as you can see in some of these pictures. And what we land up with is mission hospitals which have very old equipment. I don't know whether you can notice in the picture on the left, we have an electrocautery machine, which is from the World War days. They're so sturdy that they could be dropped from the aeroplane and still work. And on the right side, you see the ambulance, or the way the patients bring patients to the rural hospitals. And as we've been hearing in the last discussion, there are many rural surgeons who have made innovations, like the car headlamps are used for operating theatre lights. The vehicle engines, old ones bought and they convert into power generators. And way before the COVID pandemic, we were using industrial oxygen instead of medical oxygen and so on. And because of the nature of the rural areas, even diagnosing patients with the surgical disease is difficult. For example, somebody will have abdominal pain. Only when you do an ultrasound, we know whether the pain is because of gallstones or kidney stones, which are surgically treatable. So we conducted for many decades what we call diagnostic camps, where we used to take all the diagnostic facilities that we have, like the ultrasound, the cystoscope, the gastroscope, and so on, and diagnose patients with surgical conditions and operate on them in nearby areas. Now, of course, as you can imagine, these are brought with a lot of problems. For example, even when we had generator power and a backup generator, still there could be no power. And especially, one of the panelists asked about what are the problems of the new technologies. Olden days, when there was no power, we can use torchlight or candlelight to even operate. But now with the laparoscopy surgeries, we are stuck. It's difficult to do all that. So we started using the cell phone and the torchlight, and instead of encephalator, we started using nitrous oxide from the anesthesia machine. And these are some of the things which you need to sort of innovate on the spot to carry out the surgeries. If you look at the major problems which are there for rural areas, they are related to three things. Primarily the accessibility, availability, and most importantly, affordability in rural areas. So what did you go about tackling these? If you need to have some technology or some modern surgery which is available in rural areas, it has to be most of the time under spinal anesthesia. But one of them, I visited almost hundreds of hospitals and healthcare facilities in rural areas. The most difficult thing to get there is anesthesiologist, and even if we have anesthesiologists, the equipment which is necessary for general anesthesia. So anything which is possible under spinal anesthesia is really important in taking care of the patients in rural area. And of course, these equipment are very expensive. So they need to be portable so that they can be used in multiple places, and should have as little components as possible so that there are less possibilities for things to go wrong. So I'm a urologist, so we'll start with some of the urology things. So, I mentioned that in Arunachal Pradesh, we walked about 10 hours and after driving for 17 hours to reach a place. So we had a patient who, when we tested, we found that he was in renal failure. And we had taken ultrasound and we found that he had stones in the ureters, or the tube which comes from the kidney to the bladder, and is blocked because of stones. The treatment is very simple. You need to put tube to bypass the block and release the obstruction. But if it is not done, the patient will die of renal failure. So we had this scope, which is called the laptop cystoscope, which you can connect to any laptop with a USB or even a cell phone, and be able to do this procedure in that remote area. We also developed techniques to remove the kidney stones also by putting in a DJ stent, which makes the passage grow bigger, and then we can go in and remove the stone, break and remove the stones. And the previous panelist is talking about the gas insufflation-less laparoscopy surgeries or gasless laparoscopy surgeries. These are again makes laparoscopy surgery, which are very relevant to rural areas because they can get back to work very quickly, possible under spinal anesthesia. We use, if you see the picture, we use a special device to lift the abdominal wall and carry out these surgeries. And even these equipment are quite expensive and difficult for rural patients to afford or rural doctors to afford, because the turnover is less compared to urban areas. So we developed this model of equipment and human resource sharing, where the local rural surgeons, especially in Northeast, they joined together, 9 to 10 of them, and invested money and started buying this equipment. And the team used to go from one hospital to the other to carry out the surgeries. The advantage is that the investment is necessary less. And also, they can help each other perform more number of surgeries. Because when a surgeon, when he's alone, tends to perform less surgeries. On the other hand, when they have somebody to help, they're able to do more surgical work. And then the most important thing we said is the affordability. Rural patients are poor and they don't have money to pay for surgeries offhand. So in Mizoram, there's a youth organization who donated small piglets to these poor families whenever they needed elective surgeries. So they used to grow the pig and then sell it and then come with the money to the mission hospital for surgery. This worked out very well because even those who were buying, they knew the cost for which it is being sold. And they were paying them quite well. Then we started insurance programs and we worked through the grocery shops in the villages to deliver medicines, to collect money and advance money and so on. And then there is a series of adaptation which we needed to do to make surgeries possible in rural areas. One of them, we have a laparoscopic surgery, especially if you're doing removing the appendix. We use what is called the endoloop to tie the appendix, which are commercially available ones are very expensive. So we developed the same thing using what we throw away after doing a DG stenting during the one of the common urology procedures that we do. And then India is one of the diabetic capitals. We have a lot of patients with diabetic ulcers. And as when we were training in Vellore, we were taught that be very, very aggressive at the initial time. And amputation is one way of saving lives. But then recently there have been vacuum therapy machines, which are quite expensive, of course, which made wound healing possible even in these diabetics. So we worked with the Karuna University to produce a low-cost vacuum therapy units, which helped us save many limbs from amputations. And then we also can use the commonly available urology equipment for doing things which are not related more to gynecology, like infertility treatment and removing small tumors from the uterus and so on. And of course, there are a lot of cultural differences in rural areas, which you need to understand that many of those rural patients, they don't like to go to some other place, some other tribe or even the nearest city for treatment. So they would rather die in their own tribal area than go outside for treatment. And another biggest problem is that any surgical procedures involve a lot of money. They don't easily agree for treatment. So we develop these low-cost diagnostic laparoscopies. We use again the same cystoscope to show the patient and the relatives that they need surgery because there is a hole like this picture shows the duodenal ulcer which is perforated. So when they able to actually see what is happening, they are able to agree to these treatments. And interestingly, the COVID taught a lot of innovations to the rural hospitals. For example, when they wanted to screen patients to find out their temperature, it's very difficult to have all these modern gadgets which measure the temperature. So they made these long, 6 feet long phones to hand the patients a thermometer who can check and tell them. Then they were isolated in polythene bags, which are used as shopping bags, and various barriers and oxygen therapy and so on. Interesting. And here is another interesting thing is that the COVID, what it did was, it shifted all the focus of surgical work to rural areas because most of the urban centers were closed. None of them are doing surgical work. And especially laparoscopic surgery is difficult in urban areas because the many of the initial doctors who got infected with COVID were laparoscopy surgeons because there is a positive pressure system. And the abdominal contents have 10 times the viral load. So if there is a positive system which keeps spreading the virus, it becomes dangerous. So that's why this gasless laparoscopy was a big boon because it had the advantages of small incision preventing spread. At the same time, it is isobaric and not a positive pressure system. And also we can use the suction at the same time. So it is quite safe to do laparoscopic surgery using the gasless method. So now, why are we talking about all these things to primarily engineering crowd? This is because if they know, the engineers know what the exact problems are, and we also understand what are the capabilities, then it's possible to do a lot of exciting work. For example, we didn't complete it, but we did the work with the Karana University of the software to remove the smoke, especially if you do electrocautery during the laparoscopy surgeries. Then because of the smoke, you can't see anything. But unfortunately, even though it is not possible online, they were able to take the pictures and remove the smoke and software to remove the smoke and show clearly what it is. If it is made, we've gone to the next step and made it live, then it would have been very easy to continue. And one way that we got a lot of doctors to come and work in rural areas is that as medical students, I became interested in rural areas because as a medical student, I went to these rural areas and mission hospital to see how they function. So we arranged a lot of these students to come to work in mission hospitals or rural areas. So if engineering students also can come to these rural areas and see what is being done in these operating rooms, they can really of great help. I think I'll stop there because it's time. So we have been working in many universities and we can actually give real problems for you to find out the solutions. Thank you for the audience.
Your presence. Now, moving on to the last part of the session, we have with us the second panelist. The panel discussion is on technological intervention in rural healthcare, and the moderator for the session is Dr. Anurag Mishra, professor and surgeon at Maulana Azad Medical College, Delhi. The panelists include Dr. Ravi Kannan, director of the Cancer Hospital in Silchar, Assam. We have with us Dr. Peter Kalmer, associate professor, School of Mechanical Engineering, University of Leeds. Dr. Sagar, pediatric surgeon at Jawale Hospital, Jalgaon. Dr. Shajan, consultant pediatrician at Makunda Christian Leprosy and General Hospital, Assam. And we have with us Dr. Pankaj G. Jani, President, College of Surgeons of East, Central and Southern Africa. Over to Dr. Anurag Mishra to set the pace for the session.
Hi, good afternoon, everyone. Can you hear me well?
Yes, sir, I can hear you. And Dr. Pankaj and Dr. Peter are yet to join. I'm just checking with them. Maybe we can get started with Dr. Ravikan and Dr. Shajan.
Right. So thank you, first of all, to the HTIC team, Harshini and Dr. Muthu and everybody for having this meeting and getting us all together back again and getting us to think again about the much needed low resource settings and what we can do to these areas.
And meeting like this, I think, will keep us focused towards this very important area. So the task given to this panel is on healthcare technology intervention for low resource settings or rural settings. And the panel, I'm very pleased to see the panel is very learned and experienced in that ways. And we have Dr. Ravi Kannan, a very famous and very renowned, and rightfully so. He's the director of Kachar Cancer Center in Silchar, Assam, and he has been doing some phenomenal work where improving the access of high quality cancer care to much needed population of Silchar in Assam. We also have Dr. Shajin. He's a pediatrician from Makunda Hospital. Again, his experience is immense. I think we'll soon be joined by Dr. Peter Kalmer, Dr. Sagar. I can't see him in the video. Is he there? Dr. Sagar, are you there? I think if one way to describe Dr. Sagar, then I'll call him an innovator, not a doctor or a surgeon. He's an amazing innovator. A lot of very low cost innovations to his name, and very famous for that. We'll also be joined by Prof. Pankaj Jani, all the way from Kenya, and he will be putting his international perspectives on this matter. So, welcome all. If you want to give any initial comment or statement before we start taking questions. Dr. Ravi, any initial comments from you about this?
Let's get on with the discussion.
Right. Okay. So, Dr. Shajin, anything from you?
That's fine. We'll get it started. Thank you.
Right. Thank you. Thank you for joining in. So, I think my first question would be, so how do we find out, like, what are the felt areas in rural India? And both of you have worked very close to the grassroots population. So, according to you, if you have to enumerate top 2 or 3 things which needs immediate attention, so what would that be? I'll open with maybe Dr. Shajan first.
Yeah, thank you so much for having me in this panel, and thank you all other participants who has participated in this panel. So I am a pediatrician, and if we actually look at the health needs that we are seeing in this rural area, I would say the short-term needs are to improvise the health infrastructure and also to have a very good networking with uh, grassroots workers like ASHAs and community health nurses and village health workers, because they are the one who will be in touch with the rural population. Actually, we'll be sitting here in the hospital, and that is something which we really have to address something very soon, very immediately, because we got to see that in the last couple of years or so when we had this devastating pandemic. And we all realize that our public health infrastructure is in a utter chaos. So we were not able to sort of, implement any uh, health strategies or even when it came to vaccination and things like that. It was a very, very difficult task in rural area. So once you have a good networking from the NHM and from the district hospital to the primary health center and sub-center and then to grassroots workers like ASHA and village health workers, we are going to actually do a great job. We can actually implement a lot of things through this network. So I would say the foremost thing that we have to consider very urgently is to improvise the health infrastructure and to improve the networking among the grassroots workers so that we can implement things in a very speedy manner and also in an effective manner. Beyond this, I would say we would probably in the rural level, we need a lot of dedicated and trained manpower and health education, which actually needs to go
because there are, trivial things which can be easily prevented and, patients can be easily saved. But then, because of lack of awareness and lack of health education, we get to see children and even adults dying very badly in the communities. The last thing that I would like to tell is about the reliable data reporting. That is something which is again lacking in the rural healthcare system. So these are things that I would like to prioritize on: improving the health infrastructure and networking, to have a dedicated and trained manpower in the rural areas, to improve health education for the public using various methods, and reliable data reporting from the rural areas. I think these are some things which we really have to address in a priority manner. Thank you.
Thank you for a very pointed reply. I think you focused on place, people, and protocol in some way, and then you emphasized on data and how data reporting can be useful in further refining the policy and the needs of people. Thank you for that. I'll move to Dr. Ravi Kannan. Sir, what's your inputs on this?
Thank you. Thank you for including me in today's panel. I think the problems are highly contextual. Broadly speaking, we can have issues with infrastructure, we can have issues with human resources, and we can have issues with actual resources, money and consumables and things like that. And individual problems depend upon the location of the center and the nature of a center. A cancer center will have separate issues, and a general hospital will have separate issues, and an orthopedic specialist. So depending on what it is, broadly, yes, as Shajin mentioned, there are issues with infrastructure, and there are issues with human resources, lack of expertise. And to my mind, a lot of this can be overcome by wise use of technology.
I can't hear you, Dr. Ravi. Is it only
No,
me?
I'm done. No,
Okay.
I'm done.
Wow, that's super nice. Single line pointed answer. Use of technology, I think that is the way forward, and I totally agree with you. And so maybe at this juncture, we can welcome Dr. Prof. Pete, all the way from Leeds, UK. And so there's a talk about need of technology in rural India and rural other parts of the world as well. What is your take that how technology will be the answer to the rural needs, especially healthcare?
Thanks, Dr. Anurag. Yeah, lovely to join everyone, by the way. Sorry, I had some connection issues to start with. Yeah, it's a really interesting question. For those who don't know me, I'm an engineer, so I come at this from a different perspective. And I think that engineering and technology and innovation is one part of a bigger challenge in addressing these kind of challenges in providing better healthcare, more equitable healthcare. So we can't claim it's the only solution, but it fits in with providing better infrastructure, resources, training. But I think technology can really play a good part, modernizing technology, recognizing that the challenges you face in the resource context, say rural areas, are very different from those challenges that you face in higher resource settings. So you need to rethink the technology, not just take it from one place to another. So having that kind of consideration from experts who do this every day, so your surgeons who work in these settings, is really crucial. And from my perspective as an engineer, the projects that I've worked on have worked or relied really on having engineers working really closely with healthcare professionals like surgeons to understand the needs. So if we're going to design new technology, it's really important you get a good understanding of what's required, and that's built into any kind of development and innovation all the way from the start and all the way through the process. And thinking about this, I mean, my involvement has been from the UK, and we've worked with teams locally in India, which has been a real privilege. But going ahead and making this sustainable, encouraging more of that multidisciplinary working within countries, within settings, I think is really crucial. So building capacity and kind of getting people used to doing this in local settings is really important, I think.
Yeah, thank you, Pete, for that. So, Dr. Ravi, you mentioned about that it is context-based. So if there is a person or there's an institution who wants to expand to, let's say, low resource setting, how would they find out that what are the needs of that area or that context? So can you mention few important tools or some tips for us in that way, that how to read the
So
local
you have to, so it is like any other problem solving process, no? You have to go to the field and observe what is happening and then make a note of what are issues. Let me give you an example. We do a lot of cancer surgery in Silchar, and cancer surgery means we need an intensive care. We need people trained in critical care, and we don't have any of those. So what we did, we worked with a group of critical care people working somewhere else in Bangalore. We put these high definition cameras all over the place, and the critical care, that monitor can read the monitor readings and transcribe them into a paper document. The cloud physician sitting somewhere else can actually see every patient, and they guide the force on the ground to deliver critical care, and that works very effectively. A patient had a hemicolectomy done, patient had a cardiac arrhythmia and had a cardiac arrest, and the cloud physician actually alerted the nurse before anything could be done. The patient had an arrest. Patient was revived, connected to a ventilator. 5 minutes later, second arrest. Revived again, connected to a ventilator, supported. 5 days later, patient had a third arrest. Revived again. Patient went home now 4-6 months. Patient is on follow up. I saw the patient 1 week ago in the outpatient clinic. And so it can work really, really effectively. It's just that we have to feel the need and devise a solution to our own condition. We don't have these. We do a lot of surgery and then we need grossing. We don't have grossing stations. They're expensive. And so what we did, we devised our own grossing station. We used a kitchen chimney. The suction is so good, it works as good as a fume evacuator, as a regular grossing station. And so, depending on the need, we have to find our own solutions. And that can only come from people working on the ground. It could be for critical care, it could be for laparoscopy, it could be for other things, and everything has to have a local solution.
Nice. Thank you for that. I'll welcome Prof. Pankaj Jani at this moment. Yes, I can see your hand raised also, sir. So I'm sure you have a comment on that.
So thank you very much, Anurag. I'm sorry, I was in a ward round and it got a bit delayed, and I think there was a timing error. So I'm really sorry, apologetic for joining late. I just wanted to add something that we are moving in Africa, which is working quite well for us, and I think it may be appropriate for rural areas everywhere in the world, especially in the low and middle income countries. I know Peter Kalmar is for technology, and I think I would just add something before the word technology, and it should be appropriate technology, right? I think technology in many ways has helped us move leaps and bounds, but there are areas in which technology has taken us in the wrong direction. Very simply, I want to say that the mobile phone that I'm holding and talking to you on now is a fantastic technology that we can communicate, right? But it has 30 other features which I pay for and I don't use. So it has to be appropriate technology, right? Now, coming to the point in surgery, us surgeons have picked up very bad habits in low and middle income countries, especially in Africa. And because of our lack of confidence or our comfort zone being expanded, anything and everything we say, let's take it to the main theater and operate under GA. It becomes very easy for us, very straightforward for us, but we do not realize the cost involved for the main theater and general anesthesia, right? In Kenya at the present moment, a huge amount of money is actually wasted by taking patients to main theater and operating under general anesthesia. And this is what is causing a lot of problems for our poor patients. So what I am talking about is something that was devised by the president of the American College of Hand Surgeons, and it started with hand surgery. And in countries where two-wheelers are very prevalent, hand and foot injuries are very common. And all these patients were taken to the main theater and operated. And we are now reversing this trend by saying, operate them under the Volant method of care. Volant stands for wide awake, local anesthesia, no tourniquet surgery. And I would like each one of you who is working in the rural areas to plead with you that please check the Volant website, learn about it. Dr. Biju has already started practicing Volant surgery up in the north there. And we have saved 25 million Kenya shillings in the last 3 months in poor patients who came for surgery. Now, one would say 25 million shillings as compared to the billions which are stolen by the politicians all over the world is a drop in the ocean. But it's a huge amount for the poor patients who have saved this money. So whatever we can do with Volant solution under local anesthesia, you don't need the main theater, you don't need general anesthesia. Majority of the cases, you don't need inpatient care. You provide field sterility, follow the principles of surgery, inject the Volant solution, which has bicarbonate in it now. Before we were not using bicarbonate, which is a big change. Flood the area with the local anesthetic solution, Volant solution, wait for 30 minutes, go and operate. There is no bleeding or hardly any bleeding, and there is no pain. And the patient can go home the same day. So please look up Volant method of managing peripheral injuries. Our surgeons have started doing small breasts, which require mastectomies in males under the Volant solution. We have started doing amputations using the Volant solution, and it ends up saving a lot of money for the poor patients. To highlight the important points, you must follow aseptic principles, you must follow surgery guidelines, and then perform this surgery. So that was my 2 cents. Dr. Anurag, thank you for giving me the opportunity. Thank you very much.
Thank you. I think this emphasizes that how innovations can be effective and it can save a lot of cost, all that. But my question is further pointed at that how should I decide whether I want to do cancer surgery or I want to do hand and foot surgeries or trauma or something. So maybe I'll move to Dr. Shahjan. What is your take that how you decide that what intervention is needed in a particular population or a context?
Yeah, I think it's actually restricted to the type of patients that we see. Like, for example, I'm a pediatrician, I'm not a pediatric surgeon. And we work in a remote part in southern Assam, which is actually close to Tripura. So the health priority here is like, if you look at IMR statistics and NMR statistics and underfly mortality, definitely the place that I work, it's Terengganu district. It is definitely in the bottom 5 of the country. Similarly, the maternal mortality rate, it's in a very, very bad form in this part of India. So that is something that we are prioritizing because that is what is very much needed at this point in time and at this area. So I think it is purely restricted to the place where we work and the context where we are working. And, with that experience that, we gain that knowledge of where to concentrate on, which type of settings to, work on and concentrate on.
Yeah, I think use of this indirect information data which is already available in deciding the geography as well as the services which we'll provide is very imperative. Do you see value in involving the local doctors who are already practicing?
So sorry
No
to
matter what.
interrupt. We have Dr. Jnanaraj also here. He's joined us here at HTIC. I'll
Yeah.
just get him also.
Yeah, I can see them, but so we will have a 10-minute question answer where others can also participate. But I think right now I'm trying to limit it to the panelists. If there is any special comment, please raise your hands, others, and so that we can give you a chance to come in. So yeah, what I was saying is uh, that the local doctors and the local population also maybe, do you see value in involving them in deciding that what services, to what cost, how it should be provided? Any experience or any insights on that? Open to
That to
anyone who
me.
wants to go in.
Can I say it? Yes?
Dr. Sharma will come to you towards the end in the question answer session if there is
Right.
not something urgent. Yeah, thank you.
Right.
Dr. Pankaj, can you start from you?
Just briefly, can you repeat? I was with a lot of background noise. Sorry.
Okay, no issues. So the question is that do you see value in involving the local doctors and the local population in deciding the services and maybe the modality of it? Okay, Pete has got his hand raised. Maybe Pete, you can go first.
Yeah, I was just going to make a point. It touches on what Prof. Pankaj said before. I think there really is a value in involving local doctors. I guess sometimes it's challenging because of the by nature that people are spread out over a large geographic region, so it's quite difficult to access those local surgeons sometimes. But as we've touched on with technology, we have the mobile phone, we have a really good means of communicating between ourselves, and with some organization that can really kind of help tap into this group of local expertise. Firstly, to kind of understand the problems and what services could be offered locally, and secondly, to offer training between centres, which is crucial, I think. So you could look at this as a slightly more decentralised method of going about things, but I think it's really important to involve those local people and get that really local context-specific knowledge, and things like mobile technology can really help that.
Right. Okay. Prof. Pankaj, can you?
Yes, thank you very much. Sorry about that. Now, the thing is, we need to have input from all the stakeholders, right? You would want to take input from the populace and from the local doctors as well. But I think from the bandwidth capacity that we have, that becomes a little bit challenging. So what we are doing here is just like our group here, we are a panel of people who are thinking how to improve surgery, right? And we identify things which will improve. For example, we are now working on a handheld device which you do not need a radiologist for, but you just connect it to a power source and it will show you whether the cortices of the bones that you're fixed are aligned or not. So the radiologist is out of the picture, which is not available in the rural areas, all right? So if the experts meet, all right, and work on such technological improvements and then introduce them slowly to the doctors in the rural areas. Yes, the doctors must be in the loop. But I think, as I mentioned earlier, when you have intractable problems, then you need to think out of the box and you need to work on solutions. And when you have proof of concept, then we introduce this to the doctor. So what we are doing in Africa at the present moment is we are organizing workshops at all the rural hospitals. We have covered about 15 hospitals at the present moment. We are doing our workshop at Kenyatta National Hospital, which is the biggest hospital in this part of the world, I mean, Kenya, Uganda, Tanzania, Zambia, Zimbabwe, all these countries. So we're running this workshop and we're trying to introduce this technology of volant surgery with a handheld device, which we don't need a radiologist for, which will show the orthopedic surgeon that the cortices are aligned and his bone is fixed well under local anesthesia with field sterility, and the patient can go home. So we need to involve the doctors definitely, But trying to involve the populace, if we have the bandwidth and things, yes, but we don't have the bandwidth for that, and we need to move. And again, I want to re-emphasize the fact that we must have appropriate technology. Do you need airbags in a car that is not going to go over 50, 40 miles an hour? You know, I mean, we've been paying for airbags, okay, in cars, okay, and Mercedes has recently recalled 1 million cars for some other problem, right? And some of these things we really need to appropriatize to our needs, and our local engineers have to start working on it and said safety cannot be compromised. But do you need to have airbags in every car? You know, these sort of things we really need to think. Okay, and it costs an arm and a leg to have some of these things. So I'll stop there. Thank you very much, Anurag, for the opportunity. I really appreciate this, but this is what we are trying to do, and I hope if people find it appropriate, we can work more together, and we can borrow things from you, you can borrow things from us, and we look after the rural populations well. Thank you, Anurag. Thank you.
Thank you. Thank you. Very, very pertinent points there. Now, I apologize that this is sounding more surgeon heavy or surgery heavy, but the context of this talk is non-surgical, other medical specialties also. So I'll move to Dr. Shajan just to make up for that. What is your take? Because in my personal experience, I have seen many organizations where people are at the center of it. So they have council meetings, they have meeting with people who decide what kind of services they need. And it can also, you know, go over to non-medical things also, like about livelihood, about agriculture and other things also. So Dr. Shajin, your views on that?
Yes, I totally agree with you. We definitely need to take their contributions as well. Because one thing I feel is the magnitude of the problem that we face in rural areas and the extent of the problem is definitely known much better by a person who is working in a rural area. So we definitely need to take that into account, discussing with them, and when we uh, make solutions, and when we try to address some problems, it's always important to involve the rural doctors because it's been addressed for them actually. The other point is that when we talk about technology, innovations, many times the technology and the innovation that really has to be custom made for rural. The exact technology and the innovation which is meant for an urban setup may not be, exact fit for rural area. And also, when we actually involve the rural, population also, when we make plans and when we are planning of setting up a technology or any innovation for that matter, I feel including them, the results will be more. We have had 2-3 projects actually in the level people, and the acceptance also improves when we involve the local people and the rural people. So these are some of the reasons for which we would definitely have to consider rural doctors and the rural population when we think of finding solutions for rural healthcare. Thank you.
I think very right. The innovation success depends on the context. And I think context has to be defined by the local people, local doctors, and not by the felt needs or not by the perceived needs by external investigator or designer or engineer or doctor, whoever. And normally what happens is that there's a product ready, which is used in somewhere else, maybe in urban areas, that is brought to the rural areas and say, okay, will it work here or not? I think a total from the scratch approach has to be there where these people are part of the decision making from beginning. And I'm sure Pete would agree that most of the work which we have seen when we work like this, uh, we find pretty good success in that and good acceptability also. So we are in the last 10 minutes. We'll quickly move to the summary question, which is, why do you think that India is still, after 25 years of independence, we still have these burning questions of access and availability of healthcare, why technology is still not penetrated to the grassroots levels. And if you have to name 2 or 3 action points, which should be done immediately, what would that be? So that would be the last summary question, and then we'll start the question answers. So we'll start with Dr. Ravi. Dr. Ravi, are you there? You're... Okay, I think, okay, then we'll move to Pete, maybe. Yeah.
Thanks, Anurag. I think sort of reflecting on, I think one thing I've learned from my time working in healthcare in India, and it's a snapshot view, but it really hit me the first time how what a spread you have in India. So you have some of the best hospitals in the world, and then you range through all the way through to some rural settings where the resources are, really scarce. So I think that's a challenge anywhere to try and cover with a single scheme, and it maybe reflects this need to think locally and to react on a local level that is being recognised more and more, and realising that the technology and the methods have to scale to that. So we can't, I suppose maybe there's been this this ethic previously of just whatever organization takes some equipment that's used in the high resource setting and dumps it into low resource settings without the understanding that things like training, consumables, infrastructure to support those pieces of equipment have to be put in place as well. So I think maybe that's why, or a reason why that the situation is as it is at the moment. And I think going ahead is that idea of thinking and acting locally, getting local expertise and working as multidisciplinary teams. They would be my 3 take homes, I think. And I think I probably speak from quite a naive position here in terms of the clinical side of things. So it'd be interesting to hear the other perspectives that come across. But those are my observations as someone from the UK.
Yeah, Dr. Shajan. Your voice is breaking, Dr. Shajan. Yeah.
Multitude of reason.
We can't hear you, Dr. Shajan. I think it's breaking up.
Actually, look at is it no? Is it audible?
Slightly better, but still is breaking up.
Am I audible?
No, I think we'll have to come back to you after 2 minutes, maybe. So, Prof. Pankaj.
Yeah, I think you're very right that there has been a delay, but I would believe better late than never, and we need to catch up with it. Thank you.
No issues, Dr. Sajjan. We'll come back to you. Prof. Jani, please go ahead.
Yeah, so sorry. I totally agree with you, Anurag, and I think it's a question of direction, it's a question of leadership, it's a question of teams and having a vision. And we have now started focusing on the vision for the rural areas, and better late than never. So the reasons are many. We can enumerate them till the cows come home. But I think what we are doing at the present moment is really in the positive direction. And thank you very much. That's where I'll stop. Thanks.
Right. Dr. Ravi, are you there now? Okay, we'll try Dr. Shajan again. Dr. Shajan, please. Okay, so I think there's some network issue, and we'll open it to others, their inputs, their questions. Dr. Sharma has his hand raised for a long back. Sorry if we could not come to you earlier. Please go ahead.
No problem.
Sharma.
Just can you hear me?
Yes, yes, I can hear you well.
Ah, yes. So what has been said by our colleague in South Africa, I think that is the most important because education. It has to, and then the knowledge of technology, how to use it, and this can only be done in medical colleges where the students are trained. And both the things are to be put together during the training period, and then they go to the villages, they'll be more useful. One. Two, about this engineering, I have designed a small instrument long back, and I went to so many engineering institutes as this is called Sharma's cystostomy set, which I designed long back, being used now. And I tried all technically people, they all failed. And a rural man, I was told that he can make it. And I was surprised to see that the first instrument was made by this rural man, and then it came into power. So there is knowledge with the rural people, with the patient. Let us acquire that and let us give them whatever we have got. That's all. Thank you.
Very good. I think our experience also same. I think they are very
Thank you.
open to accepting new innovations and technology rather than in urban areas. Recently, we heard from the very famous Dr. Odwadia that when he started doing laparoscopies, all the rural surgeons, the mainstream urban surgeons, they kind of did not accept it very well initially.
Quite true.
And the rural surgeons were the ones who started doing it initially.
Yes.
But yeah, so I agree with you.
Yes.
Dr. Ganraj or anybody else who wants to make a comment here? Dr. Sagar is also there. Dr. Sagar? From HTIC team, anybody? Harshini, Gayatri, Nidya, anyone wants to make a comment here? Otherwise, we'll close the panel.
Have Dr. Yanraj here. Just give me a minute. He's joining.
Yeah, yeah. So while he's getting connected, I think the panel, the summary of this panel would be that the key messages at the end is to think local and use appropriate technology and invest in multidisciplinary collaborations and have a good, robust data recording system. I think these would be the further steps which can improve technology penetration in the areas and also improvement of healthcare in these areas. So I think that will be the takeaways from this panel. Dr. Ganraj, I think you are there. You're on mute, I think. You're on mute, sir. We can't still hear you. No, we can't hear you.
So is this fine?
And now it's better. Yep.
Okay. Sorry for the technical problem. So one of the things I like to highlight is that we need big cooperation. When Dr. Pankajani pointed out that all the technology needs to be appropriate.
I'm really sorry, sir. Your voice is not very clear. You have to come close to the mic, I think.
What about now?
Yes. Yes.
Okay. I'm just trying to highlight the fact we need to collaborate with the stakeholders. Like Dr. Pankajani said, the technology needs to be appropriate. And Dr. Ravi Karan also said the need has to come from the local facility, and it varies. But then it also has to be validated by medical colleges and bigger institutions to say that, okay, what you're doing in the rural areas, technology is adequate and correct and has an expert opinion. And just as the surgeons are validating what is necessary and what has to be done, it's good for engineering students also to visit these rural areas to find out their input into appropriate technology. A lot of time what happens is that in technology, the instruments and etc. are designed by people who don't have much idea of what is happening in the rural areas. If they are able to come and see, then they will be able to design appropriate technology and work on it. Thank you.
Yeah, so I think there was a voice issue, but what I could gather is he was also emphasizing on role of multidisciplinary team, where validation of the technology is also very important. And both medical colleges as well as engineering college have a big role to play in this. And we have to rise up to this responsibility of ours, where we need to do more researches on innovations which are directed to low resource settings, not only for India, but for the world. And I always say that India has to take a lead globally, especially in low resource setting healthcare area, and because we are rightly positioned for that. So I think on that note, Dr. Ravi, I think I saw that you unmuted yourself. You are here. Or anybody wants to make any remark? Otherwise, we are done. So back to the hosts.
Thank you, sir. Thank you so much for joining us today, and thank you all the panelists for your valuable insights. The session was beautifully moderated. Thank you so much, Dr. Anurag.
Thank you.
Thank you.
Thank you, sir. So now I would like to welcome Ms. Janani to give away the vote of first of all, I heartily thank you for CEO Muthu Singara for all for overall leadership and guidance. I would like to thank special thanks to seriously thanks to valuable insights. Finally, my colleague Ms. Ashini for overall coordination and also support Sumitra and once again thank you all of them. Thank you, Janani. So with this, we are closing the session. Thank you all the speakers. Thank you all the moderators. Thank you all the panel members and the startups for joining us today during this session. Hope to meet you all soon. Bye.
To everybody, thank you.
Thank you all. Bye.
Thank you.